Try sending it one more time. Okay, Marion, looks like your line's opening up.
Okay, I didn't unclick, didn't show up. Um, Good morning. My name is Marion Hollingsworth. I'm a patient safety advocate. And looking over this report, it's alarming that 94.5% of the survey respondents are licensees, doctors, if you will. Only 1% were consumers. How is this a fair and unbiased survey? You had sent the survey out to 22,000 licensees and only 55 consumers, supposedly. I'm sorry? Um, you could have sent these surveys to all the thousands of complainants who have filed with the board over the last few years to get more of a balanced idea of what's going on. These numbers seem to explain why this report seems to mirror doctor concerns and not patient safety or their concerns. On page 49, it says external stakeholders see an opportunity for the board to support physicians in their practice, enforce proper titles, and protect against unnecessary lawsuits. On page 17, this report says some stakeholders feel complainants intimidate doctors and actually favor the board taking action against complainants if their complaints are found to be fraudulent. Would this board actually do that, retaliate against consumers? It appears that doctor stakeholders themselves don't understand the primary role of the board, which, according to the mission statement, is to protect California consumers and not act as an extension of the California Medical Association in protecting physicians at all costs. I hope board members make an effort to educate these physician stakeholders as to the board's true purpose. Finally, this report doesn't indicate how much this report cost and who paid for it. Considering the board is in bad financial straits, it is in the public interest to know how much the survey will impact the board financially. I hope you will reveal the cost of the survey at some point during this meeting. Thank you.
Thank you for your public comment. Up next here we have Susan Lauren. Susan, we'll send that request to you there right now.
In whatever you do in your strategic planning session, I'd like those of you with a conscience to remember that preventable medical harm is real and rampant. Science shows that there are multiple delayed hazards from adipose removal and hysterectomies, including risk for diabetes, CVD, metabolic conditions, osteoporosis, dementia, various cancers, and more, things that all the doctors and members should know. Yet the California legislature is encouraging the removal of healthy body parts for minors and adults. The liposuction code, which does not meet a standard of care based on current science, needs to be changed. Terry Dubrow, who is dishonest, is still listed on his website as an expert for your board. No action has been taken and no answers have been given. There needs to be investigations into cases of assault, such as mine against Saul Berger, in which the medical board and DCA abetted in a cover-up to see which members of California's consumer boards are complicit in this corruption. The harm is affecting females across the board in all various specialties, and many of us are calling and asking and testifying for help, and this is not happening. I'm not going to be able to stay on this meeting. I am worse and worse from the assault, and I don't know what more I can do to communicate to the public and the board how horrible, and after 11 years of research, all the hundreds of people that I've been connected with, and yet you don't take action. What more can I do? Please look into your conscience. This is really like what the Nazis did with people standing by and not speaking up. And by saying that, I want to thank again Mr. Watkins. I'm sorry if I embarrass you by thanking you all the time. You mean so much to me and to other people that have been harmed. I ask all of you to stand up. Thank you.
Thank you for your public comment. I've noticed a few call-in users also join the meeting since we began agenda item 2, public comments. If you're a call-in user and you'd like to virtually raise your hand, you can press *6 on your phone in order to enter the queue for making public comments. If you're interested in doing that, at the time you're called, you'll press *3 to unmute your line. You'll be prompted to do all that over the phone. Next up here we have Virginia. Virginia, let me send you that request to open your line. And again, for call-in users, that was *6. Virginia, I see your line opening up. Oh, looks like you lowered your hand. Put it back up. Let's try it one more time. Virginia, looks like your line's open. Are you there? Okay, Virginia. Oh, there we go. Can hear you now.
I can hear you. I can't see you because you disappeared off my screen. So I don't know where you guys went, but I instead of focusing on what I should have, I kind of got sidetracked on last week's meeting or last time's meeting because I wasn't there because doctors couldn't tell the difference between long COVID fever and an abscess related to Clostridium perfringens, and my mom almost died, so I couldn't be there. But it's really concerning, some of the members' statements. And it's horrifying that a board member is rationalizing why the CMA is more powerful than a governmental body. The MBC should not have to lobby against its licensees that they license. The MBC should be more powerful than their licensees. And it's extremely disturbing that some board members do not understand that and instead advocating for the boards to remain complicit. Some board members don't show up to the Sunset Review or the May 6 oversight meeting. Some of them don't even know the list that the medical board had for change. And I wrote this whole thing out, but if these people don't want to advocate and stand up for patients and show up to legislative meetings and fiercely advocate for us, seriously, they should just step off and let somebody who will. If we had a board like TJ, full of TJs, we can make changes. This is life and death decisions. The people are dying, and to listen to somebody advocate harder for why they shouldn't have to advocate than advocating for advocating, then they literally should step off. And besides that, we need prevention, like the previous listener talked. This survey was based on doctors. People like me who never did a complaint was not involved because you guys would have done nothing. So I'm not even involved in this whole thing. And people who cases were not taken care of, were they involved? Did they get a form? Anyways, and please just focus on prevention, have prevention part of your plan, talk about prevention, do something about prevention. And if those who don't want to advocate and show up for things, please just remove yourself and let somebody who wants to do that. Because we need help. We don't need people who are complicit with the CMA. Thank you. And I can't hang up because I don't know where you guys are.
Try switching tabs. It's probably back there behind there somewhere. But thank you for your public comment. Next up here we have Eric Andrews. Eric, I'll be sending you that request. Good morning, Eric. Yeah, we can. Please go ahead. Thank you for your public comment. Next up here, we have Black Patients Matter. Should be receiving that request on your end.
Anna Reed, Dr. Reed, Black Patients Matter. I'm very excited to see that this meeting has happened and that we were able to be present for it. I want to commend you on the progress that's been made with the medical board over the years. So my guess is that this meeting probably the result of our ongoing federal civil rights lawsuit filed in 2018. It's never been ongoing, and we detailed the corruption that's occurred in the process, in the enforcement process. So I am the only individual here, probably in the state of California, who, or in the world maybe, who attends the meetings, who has gone through the process, who understands how corrupt it is, and how the physicians, the advocates, and the patients are being deceived. So thank you so much for having this meeting and allowing us to be here. So as we recommended in the past, a logical and just and a righteous option for patients who have been wronged is the mediation off ramp. A mediation forum, which already occurs for some other boards, I believe the Board of Pharmacy, for example, um, or Board of Building or something along those lines, where patients can have the option of sitting down, talking with the doctor, having their say, having a compromise, some type of settlement, some type of justice. And so, with the process being extremely corrupt, we're talking about uh, enforcement that changes the data, changes the facts, falsifies documents. It's all documented and ongoing in our federal lawsuit. So, because of those things that we, are limited in being able to fix, in these meetings, it is reasonable to have the option of a mediation. So I really wish that that could be addressed in new
30
legislation.
seconds remaining.
Also, I invite everyone to listen in on our YouTube channel to hear about the process. What's being missed? What's being changed? Corrupt? What is wrong? And so, also, I would ask the board to consider a clause which requires medical experts to have work
Please conclude.
history in promoting diversity. All of the medical experts are white. They come from a white background.
Thank you for your public comment. Up next here, we have Alka Eri. Alka, you should be receiving that prompt on your end. Try it one more time here, Alka. You need to be at your computer in order to accept the request to unmute. Okay, I'm move on here to Wendy Connect. Wendy, you should be receiving that prompt on your end.
Hi, can you hear me?
You can, please go ahead.
Hi, my name's Wendy Connect, and I just wanted to say that I agree with the other patient advocates about the skewed results of your surveys. And I just want to say that I hope that the board will make a concerted effort to take a look at the lack of transparency in the whole complaint process. And I think this is first and foremost something that is really against patient welfare and the board's duty to protect the public. The process is completely skewed towards the doctor, and I think that the board has to, in their heart, know that they're not giving equal time to the complainant or even considering the complainant's issues at all. And I just hope that you'll take a look at the lack of professionalism uh, in the investigators, the length of time, the complete lack of consideration to the complainant, and I hope that at some point um, you will reverse these awful situations so that the complainant has a fair has a fair chance of getting justice, as well as the public, because as you know, in the length of time that it takes, so many more patients are harmed. And as a complainant, we give over our case to you. So that is a huge responsibility for the board, which I hope that in the future it will be taken more seriously and that we can put our faith in the medical board. Thanks.
Thank you for your public comment. Excuse me. I saw Alka Ari come off mute there, so I'm gonna give you another try here, Alka. There
Hi
you go.
there, can you hear me?
We can, yeah. Please go ahead.
Oh, perfect. Apologies before.
No problem.
Good morning, everyone. I'm Olga Airy. I'm from San Francisco and a volunteer patient advocate with Consumer Watchdog. I would like to bring up access to medical records, as I'm not sure if it came up with this recent survey, and yet it's fundamental to every investigation. The medical records are required to substantiate complaints, but if patients aren't getting a complete set of records on their own, can the medical board confirm it is? How can the medical board conduct any type of investigation without a complete set of records? Thousands of complaints like mine get dismissed early on each year, and I believe lack of documentation plays a role. Medical negligence is a cause close to me because I lost my older sister to it. What happened to her could have happened to anyone. A 45-minute procedure turned into a 1-month ICU stay because her anesthesiologist breached the medical standard of care. Despite vomiting before an endoscopy, the anesthesiologist didn't intubate her. She then aspirated on the operating room table and her lungs were instantly destroyed. She was in a medically induced coma and needed both a ventilator and ECMO for a month. She survived, but now needed a lung transplant, which she never received because another hospital failed her too. The worst part of this ordeal for my sister was not the errors themselves, but the lies from her doctors. It devastated her because she had trusted them. She deserved to know what happened, but no one explained or even apologized. As she learned how to swallow, talk, and walk again with only 20% lung function, she had to process how something so unimaginable like this could happen in a well-known San Francisco hospital. We had a sense of what had gone wrong, so we requested the medical records from the hospital. We were given over 10,000 pages of records, but curiously, the few pages that made up the anesthesia record on that fateful day were not given to us. Without those pages, we had no proof that my sister had aspirated after anesthesia induction. Without those crucial pages, no attorney would represent my sister, let alone file a lawsuit, and the hospital likely knew that too. After many months of trying, I learned something new from the hospital records office. The hospital had decided not to release certain records and didn't disclose that. This occurs with records when a lawsuit is filed, but my sister hadn't filed a lawsuit. I'm not an attorney, but I also wasn't born yesterday. This isn't legal, no matter the circumstance, and yet I know of 2 major hospitals getting away with it. If they're getting away with it when patients file lawsuits, then they're likely getting away with it when the medical board investigates.
30
I
seconds.
eventually obtained the missing anesthesia records, but only because one hospital employee stepped forward. They asked me to meet at a city street corner and gave me the records in person. Had they not done so, the doctor in the hospital would have walked away from this completely unscathed. I started attending these meetings after my complaint to the medical board was dismissed to better understand the process. I've heard little to no discussion on medical records, and yet they play such an important role. I hope you will consider the issue and explore ways to ensure all medical records are reviewed and not just the ones hospitals want you to
Please
see.
conclude.
Thank you.
Thank you for your public comment. At this time, President Lawson, I do not see any additional requests in queue.
Thank you, Sean. I will go ahead and bring it back to the board then at this time. I'm just going to go over the logistics again since I took those out of order previously. I'm going to turn it over to the staff from Solid in just a minute, but we will be taking one 15-minute break this morning, and then we'll be taking another 15-minute break this afternoon. To the extent that we continue into the afternoon, we'll also be taking a 1-hour lunch break. With that, I will turn it over to Elizabeth Cornell and Tricia St. Clair, who are facilitators and strategic planners from the Department of Consumer Affairs, Solid Training and Planning Solutions. Ms. Cornell and Ms. St. Clair, please.
Good morning. Thank you. So we're here for the second strategic planning session. I am Elizabeth Cornell. Thank you for introducing me. I'm here with my co-facilitator. I'll let her introduce herself.
Good morning. This is Tricia St. Clair.
Thank you. So a quick overview of our role again. As facilitators, we're here as neutral parties. You all are the experts, board members. We're here to provide structure and document the discussion. By documenting, we will be typing up the objectives as they're being developed on the PowerPoint slide for you to see and refine and come to a consensus and draft your objectives. We will be checking for understanding to make sure that we captured the ideas, the objectives correctly. And we will try to clean up spelling and grammar on the spot, but please, we'll try to leave that to later time when we do send the draft of the strategic plan to the executives of the medical board. So today we can concentrate on the actual objectives themselves. We do ask for the board members participating to minimize any distractions. Please respect each other's contributions. You all have different backgrounds, experiences, all valid. So please respect each other's contribution and participate and contribute. Again, because you all have different backgrounds and experiences, that will make the strategic plan comprehensive and inclusive and representing a diverse stakeholder, all the diverse stakeholders, and willingness to reach consensus. Again, you may have different ideas, but at the end of the day, the mission of the board should be the inspiration for your objectives. So please be willing to reach consensus, and that consensus being the board's mission, sorry. The agenda for today will be reviewing the previously developed objectives, so licensing and board admin. Actually, board admin needs to be continued, and then develop objectives for the goal areas of enforcement, legislation and regulation, and outreach. I will quickly go over our tips on how to develop objectives. And we do recommend objectives to be SMART. And what we mean by SMART is being specific. The objective should be detailing what needs to be done, so staff and the executives at the medical board understand exactly what it is, the direction that the board members would like the board staff, the board to take. Measurable, so that success can be measured when that objective has been completed. Action-oriented, by using action words. Specifically, what is it that needs to be done? Does something need to be researched? Does something need to be created? That action word is very important to give staff specific direction on what it is that needs to be completed. Realistic, something that is possible to attain. Remembering there are perhaps resources, limitations, and budget limitations, and so on. And time-based. Time-based usually defaults back to the length of the strategic plan. So a time frame does not have to necessarily be embedded within the objective. However, if there is an objective that you place on the plan that you feel, board members, that you feel needs to have a specific time frame, you are encouraged to put a time frame for that objective. So an example of what isn't a SMART objective is better subject matter experts. A SMART objective would read something like recruit and train. That's the specific actions that you want staff to take. at least 3 subject matter experts, doesn't have to be that specific, but you can include a number, for consultation on enforcement cases to reduce investigation cycle times and improve case outcomes. So in this example, you're explaining the issue, which is, or the goal here, which is the consultation on enforcement cases, and the why, the reducing the investigation cycle times and improving case outcomes. So here, the specific part is your recruiting or recruiting and training. The measurable part is the more as subject matter experts. Here it says 3, measurable if there's any, it doesn't have to be a specific number, if there's just any indication that you can actually measure that. Action oriented, recruit and train, which is the onboarding of the subject matter experts. Is it realistic? Yes, it's something that can be done. Is it time-based? Yes, there's no specific time frame within this objective, but you would resort back to the strategic plan's time frame. That's one tip. The second tip that we have for creating effective objectives would be the objective formula, where we encourage you to use an action, a goal, and a benefit. Again, it goes hand in hand with the SMART tip here. We're using the same objective as an example. The action would be the recruit and train. The goal here is additional subject matter experts for consultation on enforcement cases. And the why would be to reduce investigation cycle times and improve case outcomes. And this is, as we're typing the objectives up, you'll see this formula on the PowerPoint. We do encourage you, the why, the benefit is really important as well, because that would give staff and the executives specific reasoning why they're doing what they're doing. So when they're recruiting and training, or creating that training, they'll know that the purpose of that training is to reduce cycle times, to improve case outcomes. So they will have that in mind when they're developing that training. Any questions, board members? No? Okay, so I will stop sharing my screen here.
All right, and I will begin sharing mine. I know I need to be made the presenter. See if I can grab that. Wonderful, thank you.
And we'll get started with licensing. We'll do a quick overview of licensing and then board admin. Okay, there you go. So this is what you had for licensing. Again, a quick overview of the goal area there. And these are the objectives that were developed last time. I'll give you a moment to review those. Okay, so it seems like we have 1, 2, 3, 4, 5 objectives under licensing. Okay, and now we'll move on to board admin.
Oh, excuse me. This is Richard Thorpe. I apologize. I couldn't get my phone or my system unmuted. Could we go back to licensing for a minute?
Yes.
And could we look at under licensing the first screen?
Yes.
Um, I, I guess the additional of addressing of reducing the time to obtain a license. We've just had a real difficult period at the end of September where a lot of people's licenses were and their employment was going to terminate because they didn't have a license. I just want to make sure we've addressed that properly. And I guess these things probably do. What it needs to say is that the time to obtain a license is I think there needs to be an actual, time period, like 90 days or something, where it's actually says there's a an actual goal in terms of how long it takes. Because currently we're 6 months out, and that's just not. It's not a functional. Anyway, I don't want to go into all the details of that problem because it's not really necessary here. But I think there needs to be. I'd appreciate anybody else's input on this, but it seems to me that there should be a time frame, like 90 days seems to me to be a reasonable time frame for an unrestricted license.
So, Dick, if I could weigh in here, because I think this is one that is, and we have spent a lot of time thinking about it, talking about it. Also, this is going to come back up as part of our sunset review conversation in our December meeting when we kind of lead into the details. My sense is that the objective actually was okay here, reduce the time to obtain a license, because that's an overarching objective. And then we're going to really be getting into some of the specifics, but it's going to require a multifaceted approach, because in some cases, we need to have people applying earlier in the process too. We need to get all their materials, and then we need to be, focused on reducing our own timelines internally at the medical board too. So I would be okay with not including a specific timeline here and making sure we have those more detailed conversations when we're teed up to have those detailed conversations, if that makes sense.
I'm fine with that. If we're going to address it in December, then I'm totally fine with that.
It will. I suspect you'll see it as part of the conversation at that meeting.
Yeah. So also briefly, I'm sorry, Christina. Yeah, so Randy and I think we had some discussions when we had the problem and we're trying to solve it for the licensees, applicants. And I also would agree that it's not necessarily here to put a time, because a time frame does exist that allows physicians in training to start the application process. And you'll hear more about that. But I think that it will be burdensome to put it here, and it may conflict with what's already in place. Thank you.
Thank you. Any other questions or refinements from any other board member? For licensing specifically? No? Shall we move on to board admin?
Yes,
And
please.
you got,
Thanks.
go ahead.
I said yes, please. Thank you.
Thank you. You all got started in board admin, so we'll see what you have so far. So you have 4 objectives so far here. Did you need a few minutes to look at some of more of the weaknesses and suggested objectives, or would you like to continue drafting objectives here? So we added some slides here to the PowerPoint. Now for each goal area, we have listed for you the weaknesses as noted in the environmental scan. And we also have listed the suggested objectives as well, or the topics here.
One of the things, I guess, just an observation here is we also have a whole section on outreach that we're going to get to later. And some of these suggested objective topics look more like outreach than they look like, or could fall in that bucket too, I guess, than they do board admin necessarily.
Would you all like to continue drafting objectives here? Let's go back to the first slide here. I don't recall whether I do believe these were all refined or finalized.
That was my recollection. Yeah.
Yes. And then the second slide, I think this was finalized as well. Reorganize committees to increase board member involvement in the important MBC initiatives. Does that seem correct? You all finalize these objectives. Unless you have any questions, any refinements, please let me know before we move on to adding more objectives to this goal area.
Lori here.
Yes.
I think one thing I wanted to add, I think board administration might be the right place, although I can also see it as a whole separate objective, is I'd like to strongly recommend that we add objectives related to diversity, equity, and inclusion. And so, for example, it could be under board administration, but maybe something like promoting or implementing DEI programs and strategies, something like that. And I can foresee under that particular action, we can easily develop tasks that are DEI focused.
Okay. And what would be your reasoning or the why? Why would they have to promote DEI programs and strategies?
Let's see, I have a bunch of notes here. To reduce health inequities, mitigate bias, increase education on cultural safety, humility, systemic racism, and bias.
Okay, sorry, I'm going to ask you to slow down just a little bit so we can make sure we capture it correctly. So we have to reduce health inequities. I think we missed something in between that and increase education on cultural safety. What was the second reason?
Mitigating bias.
Mitigating bias, okay. Increase education on cultural safety, and there was one more.
Humility and systemic racism.
Anything else you'll add at this?
I think that's good for now. We can definitely fix it later.
Yeah, this is TJ. I think, when we're talking about DEI programs, it's more of an action than just to promote it. You see, because a pamphlet can promote a DEI, maybe we can put in something more structured to develop a structured plan around DEI programs.
How about develop and implement?
Yeah, that is very complete.
I will just create one.
Thank you. Any other board members, any questions or refinements you would like to make to this objective?
I think that's great. Thanks, Lori, for the suggestion.
Thank you.
Brian, are you trying to speak?
Yeah,
Sorry.
I'm having microphone. I'm trying to turn off my camera, see if this works better. Can you hear me any better?
We can hear you now, yeah.
Yeah, I'm sorry. I'm having bandwidth issues. Do we want to put a date? Is it develop and implement by first quarter of 2023, or just leave it open-ended?
I suggest we leave it open-ended for now until we see how much more we're dealing with and committing to. personally. But
Okay,
I understand the question.
that's fine with me also.
And deadlines could also be assigned during action planning when the tasks are being identified. Thank you, co-facilitator. Any additional admin objectives that any of the board members would like to suggest?
This is Jim Helzer. Would it be appropriate to add an objective on improve our funding situation, advocate for more revenue for the board?
Funding situation, and why would you want to do that?
To mitigate our frequent concerns about stable finances, to provide revenue for additional programs, and improve our ability to
If we can slow down just a little bit, just to make sure we can capture it. So we're typing here live. So to mitigate frequent concerns about stable finances, to provide revenue for
additional programs and in support of our mission for consumer protection.
Additional programs and in support for the board's mission of consumer protection.
So Randy, I have a question. So James, are you looking at it as being a corollary to legislative? Because just curious.
That's a good point, Randy. Obviously, this may require legislative action.
This is TJ. Also a clarifying question. Is this in addition to a fee increase?
A fee increase is probably our primary tool for doing this.
Okay, so it is asking for a legislative fee increase. Is this the ask?
Yes.
I guess there's a variety of things that we could get, right? I mean, we could, the administration could overhaul how boards and bureaus are funded generally, but we are funded by our fees. So I think, but I don't think we should restrict ourselves to the available option, right? To one particular option here. I might change the word frequent to just ongoing.
Mitigate ongoing concerns. Okay. Everyone
Continuing,
okay with that?
a word like that. This is another, another issue that is already coming forward at our December meeting, right? And that we'll get into the specifics there. And I guess I want to just keep us high level here in terms of objectives from a strategic planning perspective, because we're already in the sunset review and otherwise already planning to come to you in December with a lot more information. And frankly, our specific requests of the legislature.
Any other questions or refinements to this objective? Improve funding situation to mitigate ongoing concerns about stable finances and to provide revenue for additional programs in support of the board's mission of consumer protection.
I think it's maybe more of a, I think it needs to be stated more urgently than this, because, looking at our finances without a fee increase, we're going to be bankrupt in 2 years, or if not before that. So this is not, something we can, I know the administration is not taking this casually. I know that there's a lot of effort at this, and the legislative focus is seriously. I mean, that is clearly the most obvious way to get the fee increase is the most obvious way to get this budget more close to being balanced. I I I would change funding situation to a more global approach to the budget, where the budget is or I would recommend. I'd ask for my colleagues' input here, but um, um, that the issue is the budget overall, we've been running at a budget deficit, and we need a budget surplus to be able to function in a stable fashion. And I would use it rather than improve. I would use something like uh, I don't know, a focus or
How about securing or secure?
yeah, I mean, I think the idea being we just need to make sure that this is a clear one of the primary objectives of our, because if we don't have money, we're going to be out of business here be very very long.
How about the word resolve? Resolve the funding situation.
Well, I don't think we can do that. We can't resolve the financial
Well, but
situation.
that's our action. I mean, that's what we want to accomplish, right? That's our objective, is to resolve it once and for all.
Well, I understand, but we can't do it. So I think it's kind of not the. I mean, it needs
We
to be
also,
done.
right. I mean, but we also can't improve it, right? I mean, we're
That's why I say
we're
we
on
need
our own. Yeah.
focus. We need it needs to be a focus, a primary focus, one of our major focuses, or something like that.
We can advocate for a solution.
Yes.
This is like the top of the top things we do. This is the top one or two things that we're doing.
Yeah.
Can
We
I,
use
this
the
is,
word advocate. I'd like to recommend that move to legislation and regulation from board admin.
Yeah, I think it's going to have to be in a board admin because it's more dire than that. It's we are officially or unofficially we are already insolvent because
I
we're
agree.
operating off a loan right now. So without the loan, so right now we cannot sustain this board with the current levels of income just to maintain this board.
I agree.
It's way more dire. So I mean, I think with this would have to be at the urgent level of legislative and more urgent language. I agree with Dr. Thorpe to like resolve this funding situation and really go out and advocate for all the ways in which we can get the money.
so would it stay here or go into Ledge Reg?
I suggest let's regs.
How do you all feel, board members?
Randy, again, I reacted to it because I felt it was more legislative, but if it's something that's amplifying the issue, I don't necessarily think it has to be moved, but we know it needs to be in legislative, my opinion.
Either is fine with me.
I think you're right. I think it needs to be probably in maybe in both. I don't know if that's inappropriate or not, but I mean there needs to be a focus on the administration on making sure the budget is, and that we're running as lean an operation as possible, so that there's, in terms of costs, we're doing the best we can, and then we need obviously a legislative solution for revenue.
The decision to have it either in admin or legislation regulation, really it's just the direction for yourselves and for the board staff. Either way, it's going to get completed. But I do ask a question, is there other tasks that need to be completed in order to address the funding situation? Or is it just legislative, or are there other tasks that may want to leave the objective here under admin?
I think they're really mostly, I mean, we well understand this issue, right? Our staff well understands this issue. I don't know that I mean, I really think that this is a legislative issue at this point, right? I mean, there may be some refinement, but.
Madam President, the other issue is the high cost of our from the Attorney General's office. That's a huge problem, and that is something we is not going to be a legislative fix, or at least not in the same legislation as the revenue. As the board, as the fee increase. That's it. I think it needs a fee increase, but I think we need to have some other approach to our legislative, or to our
well, that is a legislative issue, though, Dick, because that requires I mean, we're required to use them as our lawyers, right? And that's again something that's sort of out of our staff's control. We could ask the legislature to change that, but.
So this is Randy again. So I think that we spent a good amount of time with dialogue with this, and Dr. Hauser recommended it, and I think we should just leave it there as an area that, again, amplifies this particular issue. We know we have to talk about it on the legislator, and we know there's more than one fix that may need to be implemented. But I don't think we should take it out, given the amount of time we put and the discussion and us massaging it. That's my recommendation.
Thank you. And this is also something that can be addressed later with the executives when the strategic plan the draft is being finalized to be presented to you during next board meeting. So I just want to make sure we refine this objective. What action would you like to keep here? I believe it was advocate, correct?
Before we move on, this is Ryan Brooks. I want to go back to the Attorney General's office. I mean, have we ever sat down with the Attorney General and said, how can you guys be more efficient in working with these cases? I mean, I work with a number of law firms throughout the country, and we try to set up objectives and parameters around cost. Have we sat down with the Attorney General's office to define that, figure out how ways we can be more efficient to help reduce those costs?
Bill or Reggie or even Carrie, can you talk about how we typically approach this?
Yeah, sorry, can I come in here? Yeah, I mean, look, our relationship with the Attorney General's office is an extremely close one. It's one in which we have not only daily contact with them, but it's really at a very granular level. We are constantly looking at managing the cases in the most effective way. But the dilemma that we face is that it is our goal to resolve the cases as effectively and as efficiently and as many cases as possible. And so what we have seen is that across the board, activity levels are up in terms of actively managing the cases. Now, if you look at the hourly rates that were charged by the Attorney General's office, uh, I think it would be an understatement to say that they are highly competitive and they compare favorably to whatever alternatives would be there. The bottom line is this, is that we very actively manage that relationship. We have a very close relationship with them. We are always looking at ways of saving money. That is absolutely embedded in the relationship. Now, if there are any improvements, uh, I mean, perhaps what would be helpful is if we, I mean, if there are any suggestions, any ways that we can improve that, if we can improve the flow of information about how that relationship is managed to the board, I'm all in favor of that. Absolutely. Um, but I think that we have I mean, the relationship with the Attorney General's office, I mean, it is beyond a close one. Maybe, Ms. Jones, I mean, I engage with them, if not on a daily, I mean, several times a week, but someone who engages with them on almost an hourly basis is our director of enforcement. If Ms. Jones would like to fill in some of the gaps there.
Yes, and we do receive the monthly billings when we're working through a process on those to evaluate the entries. But we are involved with various levels of things to try and streamline and make the process more efficient. We've recently switched to various methods of exchanging correspondence as well as documents, and that has saved a lot of time and efficiency. So, but as far as the overall, we're always looking for ways to save money.
Yeah, thank you. This is not a question about, the quality of a relationship. We have a great relationship and they do a fantastic job. This is a question of efficiency. This is a question of how can we help reduce costs. Maybe it's technology, maybe it's new software, maybe it's, how we process on our end or their end. I think that is a healthy conversation to have. It has nothing to do with our relationship. It's, and I'm sure some of these suggestions might even help them because I know they're understaffed. And so this is a two-way effort to our mutual benefit. That's why I'm suggesting this board action.
Yeah, I agree with Mr. Brooks, and I think that looking at innovative ways, in different payment models. I mean, there are certainly other ways to retain attorneys, um, paying global fees for things as opposed to piecemealing it, and so I just think it needs to be looked at. We don't need to work out the details today.
Mr. Brooks, if I may clarify, we are approaching the technical efficiencies, ways we can be more efficient. We are translating all of the cases rather than mailing packages back and forth via mail. We're doing it all via computer software. We're also transmitting the various documents, accusations, decisions, those kind of things, electronically now versus paper. So we have moved forward with those efficiencies, and we're finding it to be both a cost savings and a huge time savings. Thank you.
Which is great. These are things we should be looking at. And the question also should be a two-way question. The Attorney General's office should be asking us how we can help them be more efficient, right? And I think that's an overall mutual goal of meeting our objective of reducing costs.
This is Elizabeth, a facilitator here. Thank you, Tricia, my co-facilitator. Drafted the objective based on the discussion that's being had. Research or explore ways to work with the Attorney General's office more efficiently and effectively to reduce costs. Board members, does this sound like an objective you would like to have on the strategic plan?
Yes.
Yes, and perhaps that can, during the action planning, perhaps this can result in a report from the board staff to the board members listing perhaps what were those methods that were identified or the ones that are being spoken to at this time and other methods that they may look at. But any refinements?
Can I just add one clarification? We should actually expand this not just to be the Attorney General's office, but we could say something like Attorney General's office and other state agencies, because whether it's DOI or others, there are other relationships where we should be doing this as well.
HQIU.
Yeah, I think HQIU is DOI now, right? Did I get that right? They changed the terminology on us.
So would you like to keep Attorney General's office listed or just leave state agencies?
I think it's worth leaving that because that obviously is one of our highest cost centers, but.
Okay. Thank you. Any additional refinements to this objective here?
Under why, I would just say to reduce costs and improve service.
Okay, and improve service. Thank you. Any additional refinements to this objective? Any additional objective board members would like to add under the goal area of administration?
Yes, I have one. I saw that there was subject matter experts, and I don't know if that is the same as board experts. But my action is to review the qualifications and the criteria that is currently used to decide who's an expert.
Could we go back just to I know there is a subject matter expert one in here. Could we go back and see if we should refine that or add a new one? Was that, I think it might have been in licensing.
I think we.
Would that be better housed under enforcement?
Yeah, that's the deal. These are issues that is within the hands of the administration, but it's under the bigger banner of enforcement within the board. So probably it will go under enforcement. That's where I had it originally. But then I saw a subject matter expert.
Maybe I'm misremembering, but I thought we had something in there about.
Okay, I don't see it in any of the goal areas. Should we copy and should we move this objective to enforcement and come back to it? Is that okay? Or would you like to address it now and then move it?
That's fine with me.
Address it later? Okay.
I think it's best in enforcement.
Just a clarification. This is Richard Thorpe. Do you mean are medical experts, or do you mean when you're talking about subject matter experts? Are you talking
I'm
about
talking about the experts that we use to review the cases, that we get it in a DAG memo and they go testify. So it's our actual board experts.
Yeah, it's the medical experts.
Okay, so it's the medical expert. So we will take that to enforcement then.
This is Jim. I don't want to get sidetracked on this, but I would add a comment about assessing their effectiveness.
Okay, so we'll add a note. And assess their effectiveness?
Yes.
Thank you.
Well, and here's the issue that I would like to have. When we review those qualifications, there's actually a criteria that I want to include, that the actual Attorney General's office be party to how that qualification criteria is created. And the reason for that is that for most of the cases that we get, they seem to have they outrightly dismiss or desecrate the board experts on a continual basis. So they would be the best people to ask to develop a criteria so that we don't have board experts failing in a case, how the whole and how it was reviewed.
Would you like, instead of review, would you like to say collaborate with the AG's office to develop qualifications and criteria, or to redefine the qualifications and criteria?
Yes, to develop qualifications and criteria that will lead to successful outcomes.
Okay, and would you like to say develop or refine, because you already have criteria in place, correct?
Yeah, I say it would be refined. Well,
okay.
It may need redevelopment.
Or redevelopment, thank you. So if we can go in there and say collaborate with AG to redevelop qualifications and criteria for medical experts and assess their effectiveness to lead to successful outcome. And is it okay if we leave it partially drafted this way and go back to admin just so we can finish the admin goal area and then we will come back?
Sure.
Is that okay? Or did you have any other ideas in mind for this objective?
Let's go back and let's come back to this in enforcement.
Yeah.
Let's finish that one thing up first.
Thank you.
May I make a comment? This is Michelle. Just if we could just use the word medical expert reviewer, because I think that's the term we use. So because I think somebody asked, are we talking about subject matter? They're called medical expert reviewers, right?
Thank you.
Thank you.
Thank you, Trisha. I added it. Thank you for that. So we'll jump back to admin just to make sure we finish that first. Any additional, double checking here, research or explore ways? Is there a preference? Explore ways to work with the AG's office. Same action, different word. Is there a preference?
I would say explore.
Yeah.
Explore. Yeah,
Explore
everybody else.
something new.
Okay,
Research
explore.
old stuff.
Okay. Any other objectives board members would like to add under board admin? And I would like to point you towards the environmental scan, the summaries under the weaknesses. There's a few items. I don't recall whether they were discussed already in the previous planning session since we did start admin. There was leadership, lacking knowledge and management skills. There was licensees wanting better support from the board when faced with allegations. External stakeholders believing board members need to focus more on board mandate, and the board, the communication and transparency. Those were just some of the summaries that were within the environmental scan, just in case you wanted to address those.
I get the sense that we're ready to move on from board admin to enforcement.
Okay.
How many have we covered totally so far? And what's left?
2, and we have 3 categories.
3 categories left?
Yeah.
Okay. What are those again, please?
Enforcement, legislation and regulation, and outreach.
Great. Thank you.
Okay, so no additional refinements to board admin. Would you like to open up for public comment for board admin goal area?
I think we need to, because I thought we were completed with that, but it sounds like we're not. Sean, are you there?
Sorry, I thought you were saying we had one more part to do. No, you want to take?
No. Yeah, I'm sorry. We need to open it up for public comment because we hadn't completed that at the previous board meeting.
Very good. Okay. The Q&A window and the hand raising feature have been activated for anyone wishing to make a public comment. Go ahead and just type anything you'd like in the Q&A box, and we can call on you to make that public comment or raise your hand. And then also to mention, for anyone on a call-in only line, you can press *6 in order to raise your hand just over the phone. First up here, we have NAMG credentialing. NAMG credentialing, you should be receiving that prompt on your end to unmute. We can hear you, NAMG credentialing.
Good morning. Can you guys hear me?
We can. Please go ahead.
Work. Okay. So I have a question regarding licensing. We have a few providers here that we submitted their apps. They got approved, I want to say in August, and they're still waiting on their pocket licenses. Is there...
If I could just stop you here, because this is our strategic planning session. And so any of these very specific questions about licensing, Bill, could you let them know, whether it's Marina or you, that who somebody should reach out to and contact, because we're not going to be able to resolve specific licensing questions on this call. The board's not going to be able to resolve those.
Yeah, if you can just contact us at licensing, we'd be happy to deal with any questions.
So if you have an overall comment about our objectives, that's fine, but any of these specific licensing questions, we just won't have the ability to answer today.
Got it. Is there at least something I can tell our providers why they're being delayed?
You can print the pocket cards yourselves. We no longer mail out the pocket cards.
That's new to us. So we can print them out online?
Yes.
Okay.
And you can find that information on the website or email webmaster@mbc.ca.gov, and we can get you handled.
Got it. Thank you, guys.
Thank you. Have a good day. Next up here, we have Virginia. Virginia, you should be receiving that request on your end.
Hello.
Virginia. Please go ahead.
So we put prevention in the board's mission, but we didn't put prevention in the board administration of it. So I think prevention should be in there. Develop and implement a patient safety prevention program to improve the health and well-being of the population, prevent patient harm, poverty, and traumatic stress, improve physician well-being, and prevent secondary trauma in physicians, save money through prevention to use enforcement, using an upstream method instead of a downstream method. And for licensing, can't say that word right, you aren't addressing the mass harm done through lobbying, which A, keeps you broke, and B, you're not addressing what the lobbying is doing to us. So you need to address lobbying through the licensee and how that is affecting the population. And also part of the reason you are broke is due to the CMA, who dropped your fees from $387 to $80, going from 47% to 10%. And your licensees did that. So you need to address that as well. And I think there's something else, but I don't remember now. That's it. So please put those on your agenda items. Thank you.
Thank you for your public comment. Next up here, we have a call-in user from the 561 area code. So call-in user, you should be receiving a prompt to press *3 on your line in order to unmute. lost my call.
Yes, hello. This is Dr. Lee from Black Patients Matter. Can you hear me?
We can. Please go ahead.
Okay, thank you. So, it was interesting. I was just reading an article about how these days in our generation or the past few centuries, there really are no real prophets, not like the days of Isaiah, Nehemiah. But I want to share, and I'm wondering if it's because they've been diagnosed with some type of mental illness. So I say that because it's inevitable that we're going to have a off lane for accusations to allow mediation. That's inevitable. So to that end, so right now, you have brought up the fact that the AG's office, very expensive. Is there some type of limits we can put on them, or something that we can offer to tell them, sort of thing? And so, if someone such as myself who's gone through the process, you could start with this: for every accusation that goes to the hearing, there is never less than four AG attorneys that are listed and working on the case. There's no need for 4 attorneys from the AG's office. Why? Because every case that goes to hearing, we're talking 100%, are always found guilty. There's no reason for the case to have 4 attorneys. The process is corrupt, it's expensive, and that is what we have to address. Thank you.
Okay, thank you for your public comment. Just going to double check here, Ms. Lawson, but I don't see any additional requests in queue. Yeah, President Lawson, we're all clear. Go ahead.
All right, so we'll bring it back. I don't know, we don't need a vote or anything on this, but is there anything anyone's heard that made we need any further refinements to board administration before we proceed?
Madam President, I would under the issue related to the AG's office, I do think we ought to at least look at the mediation issue. And I don't know what that means, but I mean, I think we ought to look at everything possible to to try to come to a solution that is sustainable, because we're currently, as TJ said, we're insolvent as it is now, and unless we get legislation that will, we already asked for legislation and only we didn't get what we asked for. So we've got to, are we realistic in thinking that we're going to get our full request? I'm just saying we ought to look at whatever we can to try to improve our budget.
Yeah, and I guess maybe it's helpful again. I mean, this is for us to tell our staff what we want it to spend, the board's time and resources focusing on over the next 2 to 5 years. And so we don't need to get into all of the details or specifics or list out all the ways we can come up with. I guess on this meeting, they're going to come back too with some more tactics at our next meeting when this strategic plan is complete, once we tell them where these areas of focus are. And so to me, I guess you're absolutely right. We should work on all of those things, but I guess I'd like to get us back up into the objectives and kind of out of the very specific details of what those ways might be, if that's okay with the group.
Well, mediation is a very different way of evaluating and processing complaints than we've ever had before. It's not like just kind of one detail. It's a very specific and different path. So I do think that we ought to look at that and not just act like we've got it. We're bound to the AG's office forever or to the same degree. We ought to try and find innovative new ways to try and manage our cases, if mediation is one of them. I'm not saying it is. I'm just saying it ought to be something that we look seriously at.
What I would say about that is that we do have staff that are listening in, and I'm sure they're taking notes. They're efficient. So I don't think it's going to be a loss, Dr. Thorpe, in any of the discussions that's occurred. But I would agree with Christina, we need to move along related to our goals in terms of the strategic plan. This stuff is not going to be lost, I'm sure.
Mr. Pacifico, do you have something to add?
Just very briefly, I mean, to me, this feeds into the whole issue of non-adversarial means of resolving complaints. I think that should go into enforcement. And yes, I think that is something that we should pursue as a board, uh, as ways of more effectively managing the complaints.
This is TJ. I agree on probably a different way of implementing that, because currently what mediation would look like is that the board undertake that negotiation, and that excludes the actual people that were harmed in the process. In order to really create an environment where a resolution is reached, I think the patients that were part of this, the doctors that are involved, and all the board and all of it must reach a consensus. What's missing from mediation, and why we're thinking about it now, is that the board represents the patients, and in my opinion, not effectively even in our current way. But I'm really open to mediation as an avenue if you bring the actual people that were harmed during the process into the process. Their statements are valuable, and I know Bill has experience in that. So I think that we should explore that. We should explore every avenue of that.
So let's move to the enforcement conversation, because mediation is an alternative dispute resolution process, right? And so that's really an enforcement issue. So can we conclude? Can we all agree we're concluding on board admin? Unfortunately, I can't see everyone's faces at the same time, so you'll have to just speak up if you disagree. All right. Let's move to enforcement. Bill, did you have something you wanted to add?
Yeah, I mean, just to pick up what TJ has said, I mean, if you look at the whole issue of non-adversarial means of enforcement, one thing that also should be encouraged is what I would refer to as local dispute resolution. So that means if you have a complaint, the first thing, I mean, what you try to do is to resolve it with the service provider. That involves the complainant effectively. And that should be a very important tool of any complaint management system. If I mean, frequently speaking to patients, if something bad goes wrong, the first thing that they want to know is what happened. They want the information. And then they want some assurance that it's not going to happen again, either to themselves or someone else. That requires local resolution involving the patient and the service provider. And that's something which we should, now that's something that of course we don't do, but we should look at ways of facilitating that, promoting that, encouraging local providers to do that. And that is one element of what I would refer to as non-adversarial dispute resolution. So I think that's something which we should be looking at.
Okay, I mean, moving to enforcement, one of the or I wanted to throw out an possible objective here that relates to our disciplinary guidelines. It's been a hot topic of late, and I think that I guess the action should probably be evaluate, and consider an update to the disciplinary guidelines.
Okay.
Why? I mean, I do think, I mean, the why is, I don't have the guidelines right in front of me, unfortunately, to see the most recent date, but it's been some time since we've updated them. And I think the effectiveness of them potentially has changed in terms of guiding our work, and there may be different standards we wish to have in place in those guidelines. I don't know the why. Maybe someone can help me with this. Bill, you've got your hand up.
Yeah, I think that's a good idea. One thing that I would like to add, of course, is that the staff have lots of experience working with the guidelines, not only from a disciplinary process, but from a probationary process. So there's a lot of learning and knowledge and experience that I think we could bring into it. And I think it's something that we should be, updating, reviewing on a fairly regular basis, and it seems a good time to do that.
And if I'm
Jim, we could add as part of the why to ensure that they remain consistent with public protection.
I have some concerns and ideas around this. Obviously, I'm the one that continually go up and say we do not follow the disciplinary guidelines. And I say that consistently because, more specifically, the probationary period, that the practice, how we practice and use those guidelines, we have already decided on what the new guidelines are. And that would look like a minimum of 3 years. And that's how we are practicing right now. But those are not public protection periods, you see. And so my concern, and I'm actually open to having this reviewed and having a really robust discussion around this. And more specifically, what would encourage the use of the mandatory or the disciplinary guidelines, and specifically the probationary period. And why I'm saying that, the probationary period is the single biggest deterrent across all the DCA boards that prevents doctors or any other licensees out of all the other boards to reconsider if they want to engage in that same practice. Everything after that is kind of like, it's just a condition. And then our track record with the disciplinary guidelines falls even further south when we see that even when a respondent or a doctor violates probation on a material aspect of a stipulation that we said, there's still an exit for them. So they've proved that they are not a candidate fit for rehabilitation, but yet we continue to go down that way. Those are the areas that I would look at reviewing the guidelines, that those things actually be closed. What this lends itself to right now, by not practicing the disciplinary guidelines like all the other boards, is that it's not uniform, there's no certainty, and it's not fair. Because most of our decisions goes the other way. And I mean, I don't want to make it a monologue. Everybody knows my position. But I'm open to this.
Mr. Watkins, I just let's focus ourselves on what our objectives are we want to review. And so we can get into all these details. We're going to come back around with this at our next meeting, and we can talk about the specifics or our opinions about whether things are or aren't working. But I'd like us to get these objectives on paper, because the sooner we can do that, the sooner our staff can actually get to work on evaluating some of these things.
I agree.
all right. Any other objectives?
I've got a few too.
Okay.
So my first objective has to do with the Central Complaints Department. So the action would be to develop a transparency model, that contains a complaint template, or a complaint template tool that can be used by the complainants to avoid the case being closed at the front end in CCU. That's my first ask.
Okay.
Is that an actual tool be developed so that we have a document? And also another goal of this is that this actually be made that when a case is closed, that it be made available. Can you hear me?
Yes.
Okay. That in the transparency model, we want first the complaint tool, which is the first part. The second part is that all the documents that relates to every part in that we receive the complaint till the case is closed. All the documents are archived and upon request can be given back to the complainant so that we don't have to explain. The documents can explain exactly what happened during the process. That's transparency, and the reason is to promote transparency.
That has potential to conflict with legislation, Mr. Walker.
And I'm happy to have that be there so that we can address the legislative aspect on the legislative side. It just points out that this is the ask, and there is everything we're going to ask is going to be legislatively impacted. Anyway, what I'm going to ask to be considered.
Okay.
I would agree with the desire for transparency. My other question, though, would be to Carrie is, does it conflict with any other part of the law? We've had discussions about this, about information we made available, and I just want to make sure that we don't include things that we know we cannot accomplish because they're illegal or some other thing that's prohibitive. I agree with the transparency, and I agree with the concept that is trying to be accomplished. I just need to make sure that it's something we actually can do. And it doesn't have to be Carrie can answer. Anyone else can answer that question, and staff.
Yeah, I mean, I think this relates also to the certain things that are in our Sunset Review report already, right? And ideas that are in progress, whether that's, oh gosh, why am I forgetting the name of the complaint unit that we will be, we've talked about previously and will be bringing forward again at the December meeting. These things do feel like they should be in the legislative bucket, either as, under what would be kind of our sunset review process or under new ideas for legislation and regulation. Also, they obviously relate to enforcement, but we can't improve our enforcement program unless we get some, in these types of ways, unless we have specific legislation that would authorize us to do those things, which we don't currently have.
What I meant,
I would put it in that would be a legislative ask, and we have asked the legislator in our prior requests to allow staff to provide a copy of a complainant's own medical records, or the patient, if it's different, their own medical records that the board obtains through its investigation. But I think that would be a better place to put it rather than enforcement, because it's not currently achievable unless there's a legislative change.
My comment about that would be similar to what part of the discussion under board administration is, that although we understand that ultimately it would require legislative changes, that this transparency concept is really an important part of enforcement. And so it's just amplifying, even though it may not be the place that it ideally is. If you have to pick one place, this would not be the place. That is, so that although you switch it to legislation and regulation, I don't know that I disagree. I think I slightly disagree with that. It would still be okay for it to be under enforcement, because it really is part of the enforcement process. And similar to the approach we use with some of the comments on their board administration that are duplicative someplace else. That'd be my comment about it.
I see with that is that it makes it look as if it's currently within the board's control. Whereas if it's placed within legislation, it's an ask that it's in the legislator's control. Yeah. We've asked for changes before that they haven't provided.
So if in fact we can't do this, then I guess I would agree with that.
Just a reminder again, I mean, we're telling our board staff where to spend their time and resources for the next 2 to 5 years, right, through these objectives. So if we tell our enforcement program, for example, to spend their time on something that they can't do unless we get legislation, I think then it's in the wrong place, right? We need to be actually telling Mr. Bone and his staff, and that team in legislation and regulation that they need to be working on these things because they're important to us. And then to the extent we accomplish that, we then tell Ms. Jones and the enforcement program to get to work, right, on improving. So I think that's the frame of reference I have for where these things should be.
So the only thing I would ask then is that to TJ, who actually raised this transparency issue, which I agree is very, very important, what do you think about this discussion, TJ?
I think is if we're going to present it to the legislature, we have to have a complete solution in hand, right? So we say we have developed, here's what it looks like conceptually. Here's the tool, here's everything. That's all I'm saying in this section, that we conceptually develop this thing that will then become a part of what the legislative ask would be.
Yeah, so Mr. Watkins, I have to stop you there because this isn't the right place to develop our legislative package. The right place to develop that package is either in our sunset review report or as part of the conversation we're going to have at our board meeting about that legislation. This is the place for us to tell our staff, big picture, objective wise, what we want them working on, right? And there are components of that, the sort of tactical pieces of that we can work on together at our next board meeting, but this is a little bit different exercise than the one I think you want to have us undertake today.
Well, then let's move it to, well, if it's not part of it, is this part of legislation and regulation? Is where we have it right now?
Yeah, so we've moved, it looks like they've moved it to the.
We good because the ask is there in the right category.
Right.
All right, thank you. So we'll go back to enforcement then. Great. Any other objectives for enforcement?
I'd like us to just go back up to look at those other three that were on the.
Sure.
Yeah.
I have two quick additions.
Please.
The earlier one, can you scroll up to enforcement? The one that said review. Oh yeah, collaborate. Qualifications, criteria, and can you add compensation?
All right.
And then also for on the line of thinking that TJ was talking about for probation, maybe it's a subsection, but maybe I'd like to know, I guess, a legal review or legal options regarding probation violations.
Okay.
I don't know if I'm explaining that properly, but the question I had was, I'm not absolutely sure on criminal law, but obviously if someone commits a crime, goes to jail, comes out on probation, if they break the probation by committing any other crime, then they break the probation. But it appears in our case, probation violation is only if they violate something similar to their original. So I was wondering, is there options to make it a blanketed probation, or what are the legal ramifications or legal laws preventing us from doing that?
Okay. And what would be your benefit?
Well, just I guess the frustration of a probation violation.
Okay, so would it be to reduce probation violation or
Increase penalties for probation violation.
Okay.
Yeah. I don't know if I'm explaining it properly. Maybe one of the attorneys could explain, could
Okay.
rewrite what I'm trying to say if you understand it.
This is Jim. How about to deter probation violations?
Okay.
Or it's not
Can I
necessarily.
take your comment, Carrie?
I think part of the challenge is that the board is limited to imposing discipline necessary to protect the public and rehabilitate the licensee. So if the violation of probation is addressable through additional terms and conditions or extending the probation, and that the public is protected with those terms, if the board decides to revoke, then that subjects the board to a potential writ and a remand from Superior Court, and the board can have to pay costs for that. So there's limitations on the board's authority, even though I understand the desire, if there's a probation violation, just to impose a revocation without considering the mitigating circumstances. But that is the board's current obligation.
So Kerry, what laws do we have to change? Because here's the problem with that reasoning, is that someone, and I'm just talking about when a material condition has been breached. Say in the cases of a substance abuse case, and now we have positive for alcohol or whatever test. In those cases, those are material, right? And when it is material, then this respondent then has demonstrated we can't rehabilitate you. At what point is the cutoff point? Because if we say you continually rehabilitative, then this process seeks to be effective. And I just am interested in what is the law that dominates that, the sections and all of it, because then we can also ask that for the legislative part when we go to sunset. I don't know what those sections are.
Well, it's 2229.1. Let me just confirm.
Well, I think that
2229
also raises, I mean, I know, Carrie, you're going to look for the Medical Practice Act in our provisions, but that raises constitutional due process protection issues too, right? I mean, very significant ones that would have to be considered if we're truly going to, permanently revoke or have an option where that happens. So, I mean, there's a lot of legal considerations, I guess.
I think that's going to be the process for a lot of things if we want to change the enforcement program. And I would rather, start, what and exploring that at least.
Yeah.
To get that onto like what are we dealing with? Because the perception is, and what is going out in the public domain is that we see this. I see that. And we say, okay, so that's what it is. The doctors are going to get their way because the laws are written for them. Right?
Well, I guess, I mean, this is something I think we need to talk about these details when we talk about our sunset report, and we need to dig in, right? Because the legislature, if anything, is going in completely the opposite direction of the one you're sort of talking about, right? It's looking for opportunities to provide people more opportunities to provide those who have been convicted felons the right to obtain licenses, that sort of thing. So we may be at odds with the direction the legislature is heading in, and with your point of view too on this. I think we can certainly have an objective that looks at reviewing our probation violation criteria terms, and then thinks about how we can do a better job of including terms that, as Dr. Helzer said, to deter these violations. And perhaps we need some more resources, those sorts of things. But these bigger picture legislative issues, I think we need to keep in our legislative bucket. Mr. Rue, I see your hand up.
Actually, if this is my thing, I want to clarify. I'm not trying to change legislation, or actually, I'm not trying to deter probation violation. After hearing this discussion, maybe I should say I'd like an analysis and clarification of the current legal review and limitations of the probation violations. So, I understand what the limitations are. So I want to know what I would like staff to analyze. What are the limitations? What are within the current law, if we could expand some of the boundaries, because I know my frustration was there are very few cases where we have repeat offenders, but then they're doing different types of violations, which does not break their previous probation, right? So I want to know what, under the current law and our current guidelines, what amount of discretion that we have or can change. So I'd like an analysis and clarification of all of that.
All right, so this is Trisha. Would you like to get rid of the review and then change that to analyze and clarify the current legal review of probation criteria terms?
We don't need the current legal review. Analyze and clarify probation violation criteria terms.
Okay.
This is Randy. I think it's clear we're going to have to help the staff prioritize some of these things we want them to do.
And when they do the action planning and they assign like the target completion dates, that's when a lot of the prioritization occurs.
Thank you.
And then, sure, uh, great point. And then if we can just make sure we get the correct why for this, the benefit.
I mean, I really think it's the same why as above almost, right? To ensure they're effective and remain consistent with public protection.
Okay.
That works for me.
Okay.
Yeah. I would like us to take our 15-minute break. I should have done it a little bit before. We were supposed to take one in the morning and then one in the afternoon and then a lunch. So let's take our 15-minute break and be back at 11. Where does that put us at? 11:10-ish, I guess. We'll be back by 11:10, 10 after 11.
Sounds good. Thank you.
Thanks. Right, if we could all try to reconvene so we can get going in about 2 minutes, that'd be great. Right, if I could have everyone on the board staff, please return and make sure your cameras are on so we know you are present. That'd be great. Do we have the DCA team back with us?
Yes, you do. And if I could have Elizabeth be the presenter, we'll get back to completing the enforcement goal area.
As we consider what else we might like to add here, I just wanted to direct the board to page 2, which has the summary of the enforcement strengths and weaknesses in the agenda report, just so we can kind of focus in on the things we might like to direct our staff again to work on big picture wise for the next 2 to 5 years. And maybe we can just do Misty and Claire, if we just do kind of a refresh of what we already have written down, and then people can add the areas they'd like to.
Sure. And I do see we need a benefit or a why for that first one, the increase specialized medical experts on behalf of the board.
Whose proposal is that? I think that is connected to the medical expert reviewers below too, but maybe I'm
right.
Not certain about that.
So you might want to consider if you want to get rid of that first one and just keep the second one.
And the second one, I believe it's supposed to be assess their effectiveness, not access their effectiveness.
Thank you.
Mr. Watkins, are you speaking? You're on mute. It looks like you're talking, but you're not.
I was on mute. I think the first one has to stay because we are continually looking for medical experts.
Okay. So would you like to offer a why or the benefit? for that one then?
To ensure adequate staffing.
Yeah.
Okay.
Could
Excellent.
I just add the word to ensure adequate and competent staffing?
Sure. Thank you.
We could also add and timely review of cases.
Okay. Great. So these three, and then I think we have two more on the next slide.
I would just like to, I mean, I don't want to get into the weeds, and if this is a discussion we need to have at the board, I'm certainly willing to have that. I just think it's important for us to recognize that, the disciplinary guidelines are recommended. They're not an absolute rule. And in fact, it states that in our, when you look at the disciplinary guidelines in the preamble to it, when we're giving people an option to stipulate a settlement, there's no incentive for them to stipulate unless their discipline is going to be somewhat softened. And the advantage for us is that it it goes into effect immediately, and their discipline comes right away. We don't have to wait for it for a hearing. So I think we need to be somewhat cautious about how we approach this, so that we don't shoot ourselves in the foot and minimize your ability to actually have a flexible and um, effective way of managing discipline, because it's not all just about you know uh, maximizing the absolute amount of discipline that we give everybody. I'm not trying to say we shouldn't I mean, we obviously need to discipline, but I think it's important to make sure that we give ourselves the flexibility to do it in a way that's effective.
So if we could, let's hold that discussion until we come back with this evaluation of the disciplinary guidelines, which we'll have as an agenda item, not in December, but at some point between the 2 and 5 year time year period of the strategic plan.
Thank you, Madam Chair.
All right, so you have 5 objectives for enforcement. Looking at the environmental scan summary, some of the items are discipline. It's a perception that discipline is not strict enough. There's concern over the time it takes to review complaints, investigate, and apply discipline. There's a perception that doctors practicing fake medicine are not appropriately or effectively dealt with. Licensees would want, let's see.
Could you go back up to the previous slide so we can see what we already have written down again?
Sure.
Where are you reading all those other things from?
That is from the environmental scan, and we do have a summary slide that, here we go. These are the weaknesses from that.
Board members, would you like me to open it up for the public comment and hear from what the public has to say, or does anyone want to add anything new before we do that?
Well, I'm sorry, I'm gonna go off video so you can hear me again. So under discipline is not strict enough or appropriate to fit the violation. What are we saying? I mean, are we saying the guidelines aren't strong enough, or we're misapplying the guidelines? I'm not quite sure what that one means.
Those are the comments, Mr. Brooks, from the stakeholder surveys.
So that goes to the guidelines, though, as I'm reading it, because we don't have.
Maybe. Yeah.
Does it go to we're just not imposing the maximum guidelines?
I don't know that we can know for sure because that's just a compilation of the thousands of responses that they received.
Gotcha. All right. Thanks.
This is Jim. We already know that it's a priority of the board staff to reduce case processing times and reduce the number of days it takes to resolve an accusation. Is it worth restating that in this strategic plan as a continued goal of our board?
I would support that.
All right, so do we want to add an objective that addresses that?
So action will be reduce case processing times and time needed to resolve an accusation.
Okay.
And Madam President, oh, sorry, go ahead, finish that.
And then the benefit, the why?
Improve efficiency.
Okay.
And
thank you.
Mr. Brooks, did you have a?
Yeah, another brief, it might be in the legislative section or enforcement section, but maybe modify or change the statute of limitations for doctors to respond to our subpoena requests or our request. Because one of the reasons enforcement takes so long, some of these doctors just don't respond or play the statute of limitations game, which is out of our control. And I don't know if this is an enforcement or if this is a legislative thing. I'm not quite sure.
That's actually one of our requests in our sunset report.
Okay. And if that doesn't belong here, that's fine also. But I think if that's a request in our sunset report, we might want to keep this as an objective if it doesn't get realized into reality.
And then
I'm sorry. I was just going to say, I think it would better fit in legislation if you want to keep that.
Because I think we're trying to tell our staff which staff are supposed to work on which things, right? And so we don't want our enforcement staff working on this issue when really that's supposed to be in legislative, because we have to change the law in order to make that happen. Once it happens, then we can move it, an issue to enforcement. I put this in. Yeah, I put this. Yeah. Sorry.
Oh, I completely agree.
Okay. Yeah. Great. We are populating our legislation and regulation objectives.
Yes.
At the same time. Are there any other additions we want to make at this time, or can we open this up for public comment and hear what they have to say, and we'll have another opportunity following that for more refinements? All right, let's do that, Sean.
Very well. Opening up the hand raising in the Q&A windows here right now. Anyone wishing to make a public comment, please go ahead and raise your hand or just type anything into the Q&A box. And for any call-in only users, you can press *6 on your telephone in order to virtually raise your hand that way as well. Let's see up here first. We have Annette Ramirez. Annette, you should be receiving that request on your end. Okay, Annette, looks like your line's open.
Hello?
Yeah, we can hear you, Annette. Go ahead when you're ready.
Okay. Thank you. I'm Annette Ramirez. I'm from Manhattan Beach. I'm a volunteer with Consumer Watchdog. I went into the hospital for what should have been a routine hysterectomy. My doctor perforated my colon during my hysterectomy. I knew I was in trouble after I woke from the surgery that afternoon, but claims of pain were considered as gas from the anesthesia. They decided to keep me overnight, but the result was the same the next day, but worse. The delay of 40 plus hours with the doctor's inaction placed me into septic shock. I spent 4 months in a coma and 2 years in the hospital fighting for my life. When I did finally leave the hospital, all 4 limbs had been amputated, my skin had been burnt from the inside out, and I now live my life in a wheelchair. When I filed a consumer complaint, I never imagined that my complaint would not be investigated. My complaint was closed at the Central Complaint Unit, citing insufficient evidence. I'm calling on you, the board, to finally provide some accountability by adopting the Department of Consumer Affairs complaint prioritization and referral guidelines. If you would have followed the same guidelines that nurses and dentists must follow, then my complaint would have fallen under the category 1, urgent category, which includes serious bodily injury, and my case would have been referred directly to investigation. I never received any accountability from this board. You can do this for me now by following the DCA's complaint prioritization guidelines and prove to me and the public that you truly want to protect consumers like me. Since my case, like many other of my fellow advocates, was closed at the Central Complaint Unit, I would like to see a policy set that would provide me some information as to why the complaint was closed. I am asking for all documents and records for each step of the Central Complaint Unit process to be made available, if requested, by the complainant. We need more information than the harsh form letter
30 seconds
provides, so we can see for ourselves exactly why the complaint was closed and which steps were taken. Finally, I am against mediation. My life without limbs should not be mediated in a non-adversarial action. Thank you.
Thank you for your public comment. Up next here we have Alka Ari. Alka, you should be receiving that request on your end. Okay, we're going to go ahead and go to Christina Hildebrand. Christina Hildebrand, you should be receiving that request on your end. Christina, you there? Your line's open. Okay, Christina, your line's open, but we're not hearing you, so I'm going to have to move on to the next request. Denise Johnson, you should be receiving that request momentarily.
Board. My name is Denise Johnson. I live in Tracy, and I'm a volunteer with Consumer Watchdog. My son died needlessly. He survived brain cancer, but died of an infection due to withheld treatment. Yet somehow the board chose not to investigate my son's case. The only representative I spoke to from the board chuckled and laughed as I explained the tragic deaths of my son. Shortly afterwards, I received a form letter that my case had been dismissed. Californians deserve to have every quality of care death case investigated. The Department of Consumer Affairs has a complaint prioritization system that requires all death cases to go directly to investigation, yet the medical board does not have to follow this guideline. I am requesting that you add to the enforcement objectives to change Business and Professions Code to follow the DCA complaint prioritization guidelines, which require you to investigate all deaths and cases involving serious bodily harm. I am also against mediation unless the complainant is physically at the mediation table and actively involved in the investigation and mediation process. I thank you for your time.
Thank you for your public comment. Up next here, we have a call-in user in the 561 area code. Call-in user, you should be being prompted to press *3 to unmute.
Yes, greetings. Dr. Rees here with Black Patients Matter. Thank you so much for being open to the idea of mediation. We really it's where we're headed, and we in California will lead the rest of the country, and if not the world. So thank you for embracing that. So speaking of problems with funding and raising physicians' fees, I'm almost embarrassed to share with you that this federal civil rights lawsuit that's been ongoing since 2018, unfortunately, has cost you, the medical board, all physicians that are licensed with the medical board, and advocates, especially ones that did not get a response or get an investigation case opened with their situation. And the reason why is because my case has absorbed hundreds of thousands, if not millions of dollars from the medical board to pay to defend themselves. And it does look like that the medical board in the state of California and other defendants are going to lose. And I will receive close to $12 million once we settle. So with the legislation, I would suggest some type of clause which inserts the fact that if the Attorney General's office has unjustly revoked the license of a physician and evidence supports that, then the physician's license will be reinstated and expunged from the record, and the AG's office must refund all the money that they spent in defending this civil rights case. So that's where the money's going. So thank you for listening.
Thank you for your public comment. Up next here we have Virginia. Let me send you that request, Virginia.
I agree. Hi, I agree with the previous statements of the prioritizing deaths and harm. If I remember right, when the CMA sued the medical board, they were supposed to use a list of case priorities, and it doesn't seem like that's being done. Enforcement should use history and stats to build a prevention model, as prevention is now in your vision statement, so that could be used for prevention. And violation not equaling penalty is kind of like the previous callers spoke, except for their cases didn't get heard at all. And like Kyra, when she bled to death for 10 hours and the doctor got probation. And I believe you guys don't even look at the amount of harm done to rate how much, what the violation should be, or the penalty should be, sorry. And for non-adversary, I can't say that. Meditation, I don't think should be used because they falsify records, they deny care, they tell other doctors nothing is wrong, they cause harm on top of harm on top of harm on top of harm. And we expect them to say, "Oh, I'm sorry, how can I help you?" That doesn't work that way. I wish it did, but it doesn't. So that theory won't work. So I keep on asking for the prevention program so we can prevent all this, and it's not being added in any of these sections. I wish you would focus on prevention. You have a list of reasons why, and I wish you would do it. And enforcement, you can't enforce if you have corrupt expert witnesses that have been cited by the federal government working as experts. So please address that as well. Thank you.
Thank you for your public comment. Up next here, we have a call-in user from the 661 area code. Call-in user, you should be being prompted to press *3 to unmute your line.
Hello, can you hear me?
We can, yeah. Please go ahead.
Oh, okay, thank you. This is Susan Shinese. I'm from Bakersfield, California. I'm a co-founder of Hospital Watchdog and a volunteer with Consumer Watchdog. After I was harmed by medical errors during a surgery, the surgery was needed due to a patient assault, I filed a consumer complaint with your board. My doctor in the clinic would not give me the medical records. After many attempts, I contacted the board. Your board staff really would not help me retrieve the records, but instead led me down a long rabbit hole that honestly required far too much effort for a very seriously ill person. I was seriously harmed and left awaiting a double lung transplant due to this harm. I lost all confidence in the medical board to consider patients and that all patients have different abilities after being harmed. I think one solution to this scenario would be for you to adopt the Department of Consumer Affairs complaint prioritization guidelines that my fellow nurses must adhere to. I was a nurse when this happened. Now another question is it time to speak on the agenda item and legislation, or will that public comment come later?
There will be an opportunity to provide public comment on the legislative objectives.
Later? Okay. That's all I have then. Thank you for listening.
Okay, thank you for your public comment. Up next here we have Tracy. Tracy, let me send you that request.
Dominguez, and I am from Bakersfield, and I am a volunteer with Consumer Watchdog. Probation monitoring. Well, we need information about how the probation monitoring system works. I want to know how many probation monitors you have. I want to know how large their region is and how many doctors they monitor. I want to know who the probation practitioner is to determine if the practitioner has a personal relationship or a professional relationship with a doctor that's on probation. I can say that I live in a smaller town and all the OBGYNs know each other personally or professionally. I want to know what process is when the public reports probation violations. With Arthur Park, we reported when he broke the patient notification portion of his probation, and the probation monitor would not accept the report, stating it was not her job. This was a special condition of the probation. It was not monitored and it was not addressed when reported. We need to be specific guidelines on how probation is monitored. All death complaints must be investigated. You must adapt the Department of Consumer Affairs prioritization guidelines. The medical board is one of the few boards that does not follow these guidelines, and deaths and lifelong harm cases are being dismissed. The CDA complaint prioritization guidelines requires that death cases be referred directly to an investigation. You will prevent repeat offenders, and you will show the public and legislators that doctors' livelihoods are not favored over patients' lives. And I am calling on a maternal mortality study to be conducted. There is a maternal mortality crisis across the state of California, but there is a crisis in my community. We cannot ignore this crisis. It is at a high level. I don't see any specific accountability methods that you are using in enforcing to help stem this crisis and make maternal health care safer in our state. As part of this study, I want to see how many complaints you have received that come from a maternal health death or lifelong harm. I want to see how many of those complaints require discipline,
30 seconds for me.
which discipline actions were taken. I want to see how many complaints were linked to a repeat offender or a suspension or other measures that were taken to protect the pregnant mothers and babies while investigating a new complaint. The study needs to be reviewed in a public setting. We need to look at specific steps that will be taken to enforce, especially with a repeat offender, to curb this crisis. I want statistics broken down by ethnicity, not race. I want it broken down between Medi-Cal, providers, and private insurances. Thank you.
Thank you for your public comment. Up next here we have Xavier De Leon. Xavier, should be getting that request on your end. Xavier, looks like your line's open. Are you there?
Can you guys hear me?
There you go. Yeah, we can hear you now. Please
Okay.
go ahead.
Okay. Perfect. My name is Xavier De Leon, and I'm from Bakersfield, California, and a volunteer with Consumer Watchdog. I'd like to start off by saying that I am against mediation. As mentioned before, we need to address the issue of 805 reporting, and it needs to start with any 805 reports received must be posted on the physician profile, such as 805 report, loss of hospital privileges, or 805 report unsustained. The reason I am so passionate about this is because I experienced it personally. I had to spend the night in a hospital with my fiance and my unborn son, waiting for a doctor to see them and assess them and offer a diagnosis, which never came. Um, and I had sat there completely unaware that a doctor had lost hospital privileges at two other hospitals in town. Um, Now, I really don't know or why or how this critical information, could be kept from us. I would like to take a guess that you guys on the board have grandchildren or small children, nieces and nephews, um, and and for a second, I'm sure that you would want to know that if your doctor had lost privileges to work in any other hospitals. Um, because of this lack of information and lack of disciplinary action taken by the board, it had cost my son's life. 805 reporting on the physician profile and 805 reporting in general must be an enforcement objective and push forward for sunset review legislation. At the end of the day, we need accountability and transparency for families. We are calling on the medical board to follow the Department of Consumer Affairs complaint prioritization and referral guidelines for death and serious bodily injury. If nurses and pharmacists have to follow the DCA guidelines, then doctors should have to follow also. Again, this is personal for me because my son died following a postpartum C-section that only occurred because his mother's preeclampsia condition was ignored. My son only lived for 18 hours. He had still lived, yet the board did not investigate my son's case. When did babies have less rights in this state? All quality all quality of care deaths must be investigated, and you must adopt the DCA complaint prioritization guidelines as one of your enforcement objectives. When a consumer complaint is dismissed or ignored, like my
30
son's
seconds
was,
remaining.
the board staff must conduct an interview with the complaint to offer the family an opportunity to provide additional information and give the family a specific reason why their complaint was dismissed or ignored beyond the basic form letter that we never received. Thank you.
Thank you for your public comment. And next here we have Monique Himes. Monique, you should be receiving that request on your end to unmute. Monique, looks like your line's open. Are you there?
Yes, can you hear me?
We can. Please go ahead.
Okay. My name is Monique Himes. I'm from Bakersfield, and I'm a volunteer with Consumer Watchdog. Adding the patient perspective to the DAG, we need balance in the enforcement process. We're asking for the patient's name to be included in the DAG memo and accusation instead of the initials or a number. We are asking for potential details surrounding the patient's harm to be included in the DAG memo, along with details about the patient that is equivalent to the details about the doctor. The doctor has due process. The patient must as well. This is the only way the enforcement process equitable for all parties. All deaths must be investigated. I'm asking you to adopt the Department of Consumer Affairs Consumer Complaint Prioritization Guidelines, which would require this board to send death complaints and complaints of serious bodily injury directly to investigation. This would have made a difference for my grandson. When I tried to submit a consumer complaint on behalf of my grandson, I was discouraged from doing so. No matter how hard we tried, the board staff insisted that it would not matter. In his mother's accusation, my grandson was referred to a fetus who lived and died. My grandson was a 5-pound baby boy who arrived by means of a live birth and lived for 18 hours. How could you not acknowledge a baby as his own person and deny him the right to his death being acknowledged and investigated within his own complaint? Had the DCA consumer complaint prioritization guidelines been in effect for this board, then this board could not have denied my grandson the right to his own complaint and investigation. This must be included in your enforcement objectives. I'm completely opposed to mediation, and I am from Bakersfield, and I am a volunteer with Consumer Watchdog. Thank you.
Thank you for your public comment. Next up here, we have a call-in user from the 562 area code. Call-in user from 562, you should be receiving a request to press *3 on your phone in order to unmute. Okay, looks like we lost the call-in user from the 562. Going back around here to Alka Airy. Alka, you should be receiving that prompt on your end.
Yes, I just did. Can you hear me?
We can. Please go ahead.
Great. Yes, I'm Olga Airy. I'm from San Francisco. I'm also a volunteer with Consumer Watchdog. Thank you for presenting your findings and listening to public feedback today. However, I wish more members of the public had been involved with the survey. Given one of the topics covered is public outreach, it's nonsensical that only 55 members of the public, compared to nearly 4,800 licensees, were allowed to participate. This survey simply doesn't reflect all stakeholders. Conducting surveys of just doctors isn't the way to improve public trust or dispel perceived bias against consumers. The public wants greater transparency engagement with the medical board. We want to be a part of the conversation. If the medical board truly wants to conduct a fair and balanced investigation that respects all parties, then I believe interviews are critical to all investigations, not just of the patient or family filing the complaint, but the doctors too. No complaint should be dismissed without an intake interview. If a complaint proceeds to the review stage and medical records are requested, then the medical board ought to share those records with the complainant to ensure it's complete and accurate. If a physician is disciplined and offered a settlement, the complainant should be notified and at least given an opportunity to share a statement during the process rather than at the end. If a complaint proceeds toward disciplinary action and a physician appeals it, the complainant should be notified and given the opportunity to respond to the appeal in support of the discipline. By engaging victims and their families throughout the process, it helps bring them closure to a horrific ordeal. Victims and families are not statistics after all. The harm suffered is real, usually catastrophic, and deserves to be handled with sensitivity. Complaints involving patient death should also go directly to investigation per the DCA complaint prioritization process. The medical board may be exempt from the process right now, but this exemption needs to be removed. If this occurs with complaints against dentists and nurses, why are we making exceptions just for doctors? We also need an appeal process for complainants. Complainants are often given form letters that close their complaints without action with no explanation. Complainants can't speak with a medical reviewer to ask why or how. Given there aren't any interviews or engagement during the investigation, complainants are left in the dark. This has to change. There's so much more that needs to be done to improve public trust on the enforcement side. The medical board does a great job engaging with licensees and protecting their livelihoods, but shows little consideration toward the livelihoods of injured patients or their deaths and what consequences that may have on families. My sense is that the board has far more engagement with the CMA than with consumer groups or patient advocates, and I hope that will change in the future. Thank you.
Thank you for your public comment. Up next here, we have Christina Hildebrand. Christina, you should be receiving that prompt on your end.
Hi, Christina Hildebrand. Can you hear me?
We can. Please go ahead.
Great. Sorry about that. I don't know what happened before. My name is Christina Hildebrand. I am from A Voice for Choice Advocacy. We educate and advocate for informed choice and transparency. I wanted to share a few things here, especially with enforcement. So, I have been listening and participating in medical board meetings now for 7 years or nearly 8 years since early 2015. And one thing that keeps coming up is this enforcement issue and the lack of consistency in enforcement. There are many people who call in, as you've heard today, where cases were just closed for no reason and nothing was followed up on. There are also cases on the other extreme, which we have been a part of or been privy to, with medical exemptions and misinformation, where the medical board, because it's a politicized issue, goes after these doctors fast and heavy and heavy-handed. And I will say, I think every single doctor that is accused and brought before the court system, I haven't seen very many that actually get off with no probation or nothing. And that's because you always find something. There's always a record keeping issue that is taken up, even though that wasn't the issue at hand. There's always something that's found. And I really think that you need to look at your enforcement and how you discipline and your guidelines and how you can do that consistently, so that on both ends of the spectrum, you're actually giving fair judgment to the doctors and to the patients, because you're not doing that currently. I think one of the biggest pieces that's missing in enforcement is the communication with the patients or the patient's family. That doesn't happen. The complaint is filed, and that's pretty much the last the patient hears, because the medical board takes that case over and supposedly represents the patient. I don't think any patient feels represented, fully represented in that case. And so I ask in enforcement that you do a better job of representing the patient for whatever that is, whether the patient is happy with the doctor or not happy with the doctor. And yes, you are there for the patient, not the doctor. But I do think, the patient needs a say. And then when complaints are closed, I agree with what people have been saying. There needs to be some paperwork or
30
something
seconds
other
remaining.
than the standard letter issued saying that the complaint has been closed and no action is being taken. Patients should be able to appeal at that point. Clearly, from the comments that have been given from these people who have had cases closed, and been severely bodily injured, there needs to be another appeal step or some further step that can happen. Thank you.
Thank you for your public comment. I have the call-in user on the 562 area code again here. I'm going to go ahead and press *3. You should be open your line. Calling user on the 562. You can press *3 to unmute your line. And okay, they keep putting their hand back down. So *6 raises and lowers your hand. Once you've been called upon, *3 will unmute your line. So 562 caller, if you'd like to. Okay, then queued up again. Let's go ahead and try to unmute. And pressing *3 should unmute your line there. Okay, so 562 caller, I see you raising and lowering your hand, but I can't unmute you if you don't hit the *3 there. Next up here we have Marion Hollingsworth. Marion, let me send you the prompt here.
Okay.
I can hear you, Marion. Please go ahead.
Here I am. Thank you. Hello, my name is Marion Hollingsworth, patient safety advocate. Regarding the comments on disciplinary guidelines, the concern here is that you are consistently levying lower disciplines than what the minimum states. Doctors know they can negotiate the lowest discipline possible. In some cases, doctors can even agree to a citation, which isn't even a discipline, for something as egregious as falsifying records to hide a patient's true condition. This happened in 2019 to an influential doctor, by the way. Also, doctors should not be allowed to get a public reprimand for an egregious death case, yet this happens regularly. You have to at least follow the minimum discipline in order to be taken seriously. If not, the board and these guidelines are a joke. The CMA approach to giving the doctor an incentive to negotiate ignores the harm suffered by the patient and only benefits the doctor. They should be able to negotiate to the minimum discipline, but not below that. Please consider revamping the disciplinary guidelines if you want to remain a credible board. I'm also against mediation because I know how biased it can be. It's an insult that board members with CMA connections are suggesting this as a cheaper way to a stipulated settlement. This suggests a strong preference to the doctors, but not patient safety. I would also like you to review the Business and Professions Code 2330 and propose a law change, because under this, patients are forced to give up all rights to their cases before the board will even consider taking it. They are then left out of any information gathering and decision-making process. 2330 needs to be changed. Also, the board should take a strong stand on mandatory reporting, because so often, even with cases of sexual misconduct, including children, they're kept within the board and not given to law enforcement where they should be criminally prosecuted. Finally, doctors who are under investigation for egregious harm should have some type of notice on their board profile pages. This would give patients some sort of notice that they can make informed choices for their own health care. Thank you.
Thank you for your public comment. 562 area code caller. I saw you come off mute there, so let's try this one more time. Should be getting that prompt on your end. Go ahead and it's *3. Okay, 562. We're gonna have to move on here. Going to Michelle Montserrat Ramos. Michelle, let me send you that request here. Should be receiving the prompt on your end. Michelle, your line's open. You there?
Yes, I am.
Please go ahead.
Good morning. I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. All deaths must be investigated. I've been telling you now for years that had you just investigated my consumer complaint, that I would have walked away. But you chose to not investigate a death that had 2 autopsy reports that stated the cause of death, which was a botched surgery, untreated surgical site infection, and sepsis. I had a death certificate that was changed to accidental death. How could this complaint not be worthy of investigation? In my investigation, I discovered that Lloyd's doctor was a substance abusing physician with arrests for felony possession of crack cocaine and multiple arrests for prostitution, all while he held a license to practice medicine in California. You need to adopt the Department of Consumer Affairs complaint prioritization guidelines. Had you done so then, my complaint would have fallen under Category 1 urgent, which would have required my death complaint to be referred directly to investigation. It isn't just me. The majority of my team's death and seriously bodily injury harm cases were all dismissed at the Central Complaint Unit. Nowhere else in California can a death go uninvestigated except in a hospital or a medical facility. This needs to change. Adopt the DCA complaint prioritization guidelines. Communication. Consumers must have input into the enforcement process. Before consumer complaints are dismissed, board staff must interview complainants before their cases are dismissed. This will not only help consumers, but will also help board staff. I also oppose mediation unless the complainant's family member is at the table and involved in the mediation process. Yes, we want to know what happened and that it does not happen again, but the only way that we can stop egregious conduct and egregious negligence is by disciplining the provider responsible adequately. Thank you.
Thank you for your public comment. Calling user 562. I see your line's open now, so I left you open there. Are you there?
Yes.
All right.
Can you hear me?
We can hear you now. Yeah. Please go ahead.
Okay, thank you. I'm Evelyn Martinez. I'm from Linwood, and I'm a volunteer with Consumer Watchdog. My son died tragically at just 5 years old from medical negligence. I want to make sure that all children who die have a chance to have their deaths investigated. I'm asking that you make sure that our deaths are investigated by adopting the DCA complaint system that nurses and dentist complaints must follow. If a child dies like my son, then the complaint must be sent to investigation. It is only fair. Please show me that our children's deaths matter and implement this issue as part of your enforcement plan. We need accountability. I'm asking that each record and document that is created in the Central Complaint Unit is made available to the person who files the complaint. Over 50% of cases are dismissed at the Central Complaint Unit. We need answers why these complaints are dismissed. This change will provide us some answers that we need to make the best choice for our families. Thank you.
Thank you for your public comment. Have a call-in user from the 561. Need to make sure this isn't a duplicate. Call-in user, you can go ahead and press star 3 to unmute.
Yes, hi, Dr. B.
All right, it already had a public comment. I can't see the full number, so I just wanted to make sure it was a duplicate there. Next up here, we have Wendy Connect. Wendy, you should be receiving that prompt on your end.
Before I forget, I wanted to thank the board for supporting AB 1278. And we did get it passed finally, and not exactly everything we wanted, but thank you again. And hopefully that's one little step towards patient safety. But I wanted to discuss the lack of transparency when it comes to enforcement. Beginning with the Central Complaint Unit, where so many valid cases are dismissed on a daily basis. But then when cases are taken in for review, the complainant then becomes secondary, and trying to get any information is virtually impossible. In fact, you're treated like the you're treated like the perpetrator when you try to get information. But in my case, I sued, so I did get some information, and it was and we got the only way I got to see what the doctor responded to my complaint was because of discovery. And in that case, it was like 10 pages of lies, but I never got a chance to talk about that or get even have any input on any of this that I would never have seen. And just as an aside, also, my husband is a doctor. When this happened, he's like, "Oh my God, the doctor's going to get, that's it. You lie to the medical board, and that's it." But this was like almost 4 years ago, and nothing's happened to that doctor yet, even though there's more complaints that have come in. But one issue is that we can't see what the doctor writes. But what's more astounding is to find out that the medical board doesn't even see what the doctor writes or what the complainant writes, that you have to depend on the review from the Deputy Attorney General. To me, that just seems so wrong and so askewed. And I heard Mr. Pacifica say that you have a strong relationship with the DAG, but what is that relationship, and what is the DAG's relationship from the Attorney General's office with the CMA? You just have to wonder about that. And I wanted to say also regarding the disciplinary guidelines, perhaps the mistake is calling them guidelines, as it was pointed out. Maybe they should be converted to mandatory discipline. And that way, there's no gray area, because it seems when there is gray area,
30
it
seconds.
strongly favors the doctor. Thanks for listening.
Thank you for your public comment. Next up here, we have Kimberly Turbin. Kimberly, let me send you that request. Kimberly, there we go. Your line's opening, Kimberly. You there?
Hello, my name is Kimberly Turbin. I'm from Los Angeles. I'm a volunteer with Consumer Watchdog. So I want to talk about us needing accountability and transparency for patients and families. We are calling on the medical board to follow the DCA complaint, prioritization, and referral guidelines for death and seriously bodily injury. If nurses and dentists have to follow DCA guidelines, that doctors should have to also. I'm calling on the board to follow the DCA complaint prioritization guidelines, which calls for deaths and seriously bodily injury complaints to go directly to the Division of Investigation. I'm calling on the board to bring the Enforcement Committee and the Public Outreach Committee back to the quarterly board meetings. The Enforcement Committee provides more in-depth information for the public, which will educate families on how the enforcement process works. We're only receiving limited updates at the quarterly board meetings. Bringing back the Enforcement Committee to meet in public will bring more transparency to the enforcement process. Please include this in the enforcement objectives. Maternal mortality is at a crisis in our state. I don't see any specific accountability methods you are using to enforce to help stem this crisis and make maternal care safer in our states. I'm calling on any maternal mortality study to be conducted. I want to see how many complaints you have received that come from a maternal health death or lifelong harm. I want to see how many of those complaints require discipline and which disciplinary actions was taken. I want to see how many complaints were linked to a repeat offenders and if a suspension or another measure was taken to protect pregnant mothers and babies while investigating a new complaint. This study needs to be reviewed in a public setting, and we need to look at specific steps that will be taken within enforcement, especially with repeat offenders to help curb this crisis. Thank you.
Thank you for your public comment. Up next here we have Eric Andrews. Eric, let me send you the request. Just find you here. Okay, you should be receiving that request momentarily on your end. Yes, please go ahead. Thirty seconds remain. Thank you for your public comment. This time, President Lawson, I don't see any additional requests in queue.
All right, I'll bring it back to the board. Are there any other changes, I guess, we wish to make to this enforcement objective section, section, excuse me?
Yeah, it's TJ.
Mr. Watkins, go ahead.
I think what came through loud and clear from the patients, and I've just been reading this, is the DCA prioritization guidelines and referrals. And just to adopt them, just adopt them.
I think is the right, yeah, is the right action though. I support that, but is the right action to evaluate adoption? My understanding is there's some legislative prioritization for the board too, and I think we probably want to make sure we know what we can and cannot do. Maybe bring that back at another meeting.
Or we could just put it in legislation, because everything that is going to be asked, I mean, I've got a list here with 3 things that I've heard continually show up, and it looks like no matter what we're going to ask, and that was my initial, gut feel, that no matter what is asked, it is already legislatively written in a particular way. So it's going to require legislative action anyway. So maybe we should note this and put it in the legislation and regulation part.
Ms. Lawson?
I have a question.
Please.
I was going to ask,
Go ahead.
I was going to ask Carrie or Jenna to actually help us with this so we actually understand, because I'm embarrassed to say I actually don't understand. It would seem to me that this would be a no-brainer, but I may be missing something.
Right. The board does have prioritization of allegations under Business and Professions Code section 2220.05. And the top category is gross negligence, incompetence, or repeated negligent acts that involve death or serious bodily injury. And I suspect that the issue relates to the review that the board is required to do in quality of care cases before the matters go to the field. And that's under Business and Professions Code section 2220.08. So it's not an issue of priority. These are priority cases where serious bodily injury or death is involved. It's the pre-review required for quality of care cases.
Maybe I don't even understand what that means. So in the quality of care cases, I'm hearing you saying, you have to correct me here because I just didn't understand that, was under 2200.8, it's already a priority that death cases and serious bodily harm cases will go to an investigation.
No, it's 2220.05 sets the board's priorities, and cases involving death or serious bodily injury are already the board's top priority. But the section 2220.08 requires the board in quality of care cases to send that case first to a medical consultant before investigation. And so at the central complaint unit level, following the medical consultant review, the case can be closed for no violation or insufficient evidence. Cases where the medical consultant find that there is a reason for further investigation, those go to the DCA for field investigation.
So what I'm hearing here is we actually need to have a review of our that particular process potentially, but I'm not even sure it's that narrow. It might be broader than that because we have the patient advocates using terminology that is different than the terminology we're all using too. And so I'd like to have us come up with an objective that has us actually review this. I don't know if review whether the DCA's complaint prioritization would be more appropriate or what the right terminology is, but I'd like us to have us review this, but I don't know that we can reach any kind of result about what we should actually do on this call because we're not all aligned even on what the specific issue is here.
This is Jim. We had discussed earlier possibly assessing the effectiveness of our expert reviewers. How about assessing the effectiveness of our clinical consultants in the central complaint unit?
How many medical consultants are in the central complaint unit right now? Because
so I got to keep us kind of on track because we have 3 more things and I can already see we're going to be past 4 if we don't do it. So this level of detail, we need to get into at a meeting where we put it on our agenda and we all ask these questions and we figure it out. So what should we be asking our staff to help us look into? Like, is it that we want to analyze the consultant program? Because what I'm hearing from the advocates is it's something different. They actually want us to look at our prioritization of cases. And I think I'm hearing Ms. Webb say she thinks that probably means they want us to be required to investigate all of these rather than do what we're doing now. But we really need to do a deep dive and understand why it is the case that we do it the way we do right now. And do we want to make any changes to it in response? I think that's the issue. And none of us, I don't fully understand it. Ms. Webb, I think, understands it, but I don't think any of the rest of us know exactly how this process works right now.
I
agree, I'm not sure.
I think an analysis would be good, and also to get some kind of a actual statistical breakdown about how many of these cases that actually go through this system then gets closed by just being reviewed by a medical consultant. I would like to see if we analyze it, to have actually good data that substantiate the findings of that really works through the analysis. When it gives us a result, then we can follow it through it.
Great. Ms. Webb, can you help us help us articulate what we want to analyze based on what you've heard?
I'm taking a look at it here.
Okay.
I mean, maybe analyze Business and Professions Code section 2220.08 to determine its basis and the and its appropriateness, and whether any changes are necessary for consumer protection.
How does that look to the board?
I'm just wanting to see, will that be like will that be a statistical and a statistical number as well as give us some qualitative feedback about, what I mean is, do I see, for example, like we get so many cases get referred to the medical expert that involve bodily injury or harm, and how many of those things are just closed? And
So,
what
Mr. Watkins, at our next meeting, they're going to come back with their action plan for how they're going to implement this objective, and that type of detail will be in that implementation plan. Or if it's not, you'll need to make the comment then, right?
Yeah, I just want to make sure that that is the detail. and that we just don't get, like, no, it's not appropriate.
This is Randy. I just wondered whether we're going to be able to get the type of details being asked by that board meeting, because I thought what you were asking was that we actually given a presentation about this code, and so we can analyze where it falls short relative to what the consumers are asking. Are we not doing? And then, because I'm just asking, should this actually stay here in enforcement? I thought we were trying to understand better where we may fall short, or better understand what it is that the consumers are asking, and that I think, well, that's obvious that we should be doing that. But I'm just wondering whether it still needs to stay here. Clearly, we need to hear about it and have a dialogue about it. And I hope that isn't too confusing. Christina, what were you asking?
Well,
I think the
so
consumer.
I think this is in the right place because our enforcement program needs to take a look at the enforcement priorities, and the legislation's already in place before we can even figure out whether we would want to change anything. A reminder, this is not coming back at the next meeting. Their implementation plan or their action steps are going to come back, but this is a 2 to 5 year plan. So don't expect to see all of these various things coming back as agenda items at our next meeting. There's a whole lot of work to do, and we really will need our staff to prioritize this work because we can't do it all at the same time with the limited resources that we have. So I think this is the right place for this, to just understand this issue. It's the first time I've heard this issue raised in this way, also, and so I think there's more work to do.
Madam President, I just had a question, and maybe Ms. Lawson could or Ms. Webb could answer this question, but I think that the medical concert, I don't think we have, I'm not aware that we have consultants in the central complaint unit. I think the central complaint unit uses our medical expert reviewers to refer those cases to. Is that not correct?
Yeah.
It's different. It's a different group. They are not located in the central complaint unit. They're contracted with to do these reviews, and they're different than the expert reviewers that evaluate everything after investigation and testify at hearings.
Okay, thank you.
All right, this is Tricia, and based on the first objective we see here, can we delete the one that's highlighted now?
Thoughts?
I would say yes.
Okay.
Wait, isn't it no? Didn't you just say that they're different people? Or someone said that?
Yeah.
Can we go back up to the first page of the enforcement section? Okay.
And then do you want to see the next screen?
I guess I'm asking myself a question about whether or not anyone's actually, unlike expert reviewers, where there has from time to time been some concern about whether or not we have the right cohort of those people, and how we could increase the sophistication potentially. I guess that's my word. I don't know that we've had the same issues with the consultants that work on these cases up front, but I don't know the answer to that question. I just don't know if it's something that's necessary for us to direct our staff to work on in the same way. Okay. But that's for, potentially others to weigh in on as well.
If there is a concern that they're closing cases inappropriately, maybe we should take a look at their process.
Yeah. I agree, and I would just say if we're going to keep this top line here on the page you just flipped, I want to make sure we're using really good language. Could you go back to the prior slide where you say special, the one you just had up, sorry, this line, specialized medical expert reviewers on behalf of the board. What is the proper terminology? Those are the consultants. What is, they're not specialized medical reviewers. Can someone say how they're referred to? Are they specialized consultants? Because we don't want the medical expert reviewers. I don't think that's what this is talking about. Just for clarification.
These would be, this is Jen, I apologize. These would be the medical experts. These would be the expert reviewers that review the cases.
Oh, I thought these were the people that were at the, that went from the complaint unit over to the review before it goes to investigation. Sorry.
In our internal language, we call those medical consultants.
And is that what this line that's gray on gray talking about, medical consultants? Because it's talking about, no, it's to ensure adequate and competent staffing and timely review of cases. You don't staff with medical expert reviewers. I'm sorry, so I apologize. I just wanted to be clear. It's not clear.
No, the medical experts are contracted. We contract
yes,
with.
I used to be one, so I'm familiar with that.
Right.
I think that I understand that. I'm just asking one question. The why, to ensure adequate and competent staffing and timely review of cases. To me, that speaks to the after the complaint is filed and then it goes to that consultant. And that person then writes a report that medical expert reviewer actually sees, as I recall.
I would just change that to experts.
Yeah, I thought these were the experts that we're speaking of. The ones
Sure.
who we read in our cases, the
Mhm.
expert who reviewed everything and gave an opinion. I thought that's who these individuals are.
Okay.
Is that right, Jenna? I mean,
Yes, that would be it. The wording before was confusing, so I appreciate the clarification.
But again, there's a group of folks who look at cases before these cases get to the expert, and those are up front. And I think that the question is whether we need to look at that process too. And it sounds like we do because they make a decision about whether the case even goes forward.
Correct.
Isn't that among one of the last things that was presented, one of the last ones?
It is, and we need a benefit or a why for that objective if you're to keep it.
So I think it has to do with assessing whether cases are being appropriately referred for further investigation.
Okay.
Simply because we're being told that, why was my case closed? I think this is the appropriate area that tells us that, answers that question.
Yes, sir.
Okay.
I believe we're asking for that. I'm asking. I think that's reasonable. That's a reasonable ask.
Okay.
Madam President, I have a question. This is Aaron. So, since the medical consultants are the individuals involved in the process in BPC 2220.08, seems like those two goals that we have on screen right now are somewhat in parallel, and perhaps they could be consolidated. Because that is the process that we're talking about in that code section is uses medical consultants in that CCU evaluation.
Yeah. I mean, so I guess, the second one there, assess, is actually encapsulated in the first.
Yeah.
Okay.
Thoughts on whether we need it separately? Maybe we should just, should we leave it as is, and then the board, board staff, when you come back with your plan, you can have it be a sub-bullet rather than a separate item?
Suggest some cleanup in the process. Is that kind of what you mean?
Yeah.
And what you're creating today is a draft, so it will be sent to staff for their suggested edits as well. So this is just a draft today.
Okay.
All right, so you now have 8 objectives for the enforcement goal area.
And am I correct? Weren't we trying to get to 3 to 5 on each one?
3 to 6 is generally the recommended. I mean, certainly if you feel more are necessary, then you can create more. And that just
I just
maybe
want the board to be mindful of the fact that we're already over the number of
yes.
recommended objectives, and that
Yes.
will limit what we can actually accomplish at any given time. Okay, are there any more in enforcement, or should we move on? Okay, moving on, I guess.
And just want to put out a question out there. Would you like to break for lunch now before moving into legislation and regulation?
I suppose we can break for lunch. Can we take 45 minutes and try to have everyone back? It seems to take us 5 or 10 minutes to reconvene once we get back. So if we could set that time at what time? 1:15 to be back. And then we do need to power through these last two by 4 p.m. We can't extend this any further.
Okay.
Deal? All right. Okay, we'll see you at 1:15. Thanks.
Our second slide up. I thought we had more. We have two. So the second one is modify the statute of limitation of doctors, or I'm not sure if you meant to say licensees, to respond to the board request, and what would be the reason for that?
This is one of those very, very specific requests that actually is already included in our existing proposals.
Yeah, with that one, we're seeking to toll the statute of limitations or push pause on the statute of limitations in cases where the board is getting bogged down in a subpoena process for records. So that's the impetus behind that particular proposal. But yeah, I think to your point, Madam President, this feels like a discussion point at the December board meeting. It's very targeted. It's very specific. And it feels like for something for consideration at the board's discussion in December rather than a strategic goal.
Right. So I would actually delete this because it's something that's already in process as part of our proposals, and we know that we're going to have a conversation about these issues in December. And so coming back in December with a plan to have these things doesn't seem to me to be the right fit. One thing that we're headed into sunset review, for the third time in 5 years or something. One thing that I actually would like to achieve, and I don't have the wording for this yet, but is allowing the board to have a 4-year period where we do not have to go through a sunset review process in the interim, so we can actually work on achieving some of these things. The sunset review process is extraordinarily time consuming, and to go through it once a year or every 2 years, to me, doesn't make a lot of sense because we don't actually get to make progress in the interim necessarily. So I'd love for us to have some more runway to work on some of these things without having our staff and our limited resources time be taken up by complying with the sunset review process. To me, that means 4 years, which is what we used to achieve during that process, if memory serves. And I don't know, again, what the action would, but, advance 4-year proposal for, I don't know what the right term is. Aaron, you can help me with it, but I don't know if there's support for that.
Well, and I think that is something that's, I don't have all the documentation from it. I think that is something that's that we're planning to put forward in December already.
Yeah.
Would it be just to achieve as the action a 4-year period prior to our next sunset review or something like that? I mean,
It could be, I mean, maybe even broader. I mean, sufficient time and resources to, I don't know,
Well, the issue is sunset review. The issue is sunset
right.
review. It's not sufficient time and resources. It's the issue is
We need both, right? Yeah.
achieve um, sunset review, or achieve the next sunset review at the most appropriate time interval.
Yeah. I mean, is it reauthorization for, 4-year or more time period?
Is it a minimum 4 year though? Isn't that how it works?
Yeah.
It used to, but they reduced it, right? And we're back again, having been through this process.
So I think you should put
But
something 4 years or longer. I think you should put the 4 year somewhere in there.
Yeah,
I
4
agree with
years is
specifying 4 years to be specific as to our goal.
I think we must understand what happened at Sunset Review in context because of the back and forth negotiations that was happening in the backdrop to it with regard to the fee increase and all the elements that we were asking for at Sunset Review. And I think that that was the settlement. I don't think that is the norm. It hasn't been the norm. So, if you want to make an overt legislative ask for it, then absolutely. But I think that was just an outlier, considering all the issues that is on the table.
No.
And to see how the board would respond in the 2-year period.
Well, the point's well taken, but I would agree with Christine, who was actually much more involved the day to day with Sunset Review as a president, that they need to hear that this is not something that we want them to get comfortable with, because it gets in the way of us actually executing our really to be more efficient in executing the goals of the medical board.
Yeah, I worry deeply about the diversion of time and energy to a legislative process that should more appropriately be, that those time and resources should more appropriately be spent on our licensing and enforcement programs, right? But instead, we spend a whole heck of a lot of time on these processes if we don't do them at the right time. And then you can't achieve gains, by the way, in an agency like ours in a year, right? You need some time to develop programs and implement them. And that's what I want us to be able to have time to do outside of this process.
Madam President, you could just say the next sunset review in 4 years, at a 4-year interval or something, just so that it's if I think it's I started out saying 4 years and I changed it because
right.
Yeah, there was a
Or we can just say just restore the 4-year sunset review period, something to that effect.
Well, maybe that's the action, is restore the sunset review to a 4-year interval or something.
Okay.
Yeah, thanks, TJ.
Okay.
And I think it's the why is to avoid diversion of time and resources from our active goals.
Yeah, I like that. I'm fine with that as written.
Any other refinements or questions, discussions for this objective?
So, Christina, do you think it's inappropriate to put in here? Because I think there's going to be to put in here the fee increase.
I think we put it in somewhere else, but I don't think it's necessary because it's already part of the package that's advancing as part of sunset review.
Fine with me.
Yeah. And we're going to spend a lot of time talking about all of that at next month's meeting.
As long as it's somewhere.
Right.
Strategic plan.
Well,
as long as it's somewhere.
It's in the board admin. We spent some time on that this morning and ended up with it there. It obviously requires legislative action. Aaron, is there anything else you think you would need from us? I mean, is there in this section, or should we open this up to public comment and hear from the
I have
public?
to ask
Yeah.
before the public comment, and it's something that's been shot down, but I feel very strongly about this, and that is a change to Section 2330. And my issue here is right now, patients do not have a legal right to the enforcement process. After we take their statement, then we never the board never gets to review it. Us board members, we are only privy to the DAG's interpretation of that statement. The problem with that is the patient is presented to us with no name, so it's not a person. It is a Jane Doe or John Doe equivalent as patient A. There's no backstory. There is no appeals process for them. There's no notice that they get when things of how the process is moving along. So in essence, they have no rights in the process. And some of the DAGs have said that they don't have a property right. And that means the patients do not have a right. So the board, once they give that complaint to the board then effectively can ignore the patient. I'm asking this, the why for asking this, I just want to restore the patient's rights in this enforcement process. Now, this has been overlooked tremendously because every time we want to do something, whether we put on a liaison or anything, those are not legislatively required. That's the board doing whatever the board does policy-wise, and they can choose not to do it. I would rather prefer that the patient's rights be restored under this section so that if I want to see, and that's why I suggested the template on the complaint at CCU, then we could see a actual formatted complaint where we can give input about how we want to receive it, much like a DAG document. The biggest issue that I have with regard to the current process is that the doctor is presented as the only person on that memo. His qualifications, his backdrop, everything that has happened to the doctor, and it's impressive. But what it does, it creates, it shortens the psychological distance between doctor and doctor and increases the psychological distance between the board and the patient. We don't see them. We don't know anything about them. I would like to know, is this a single mother who just lost a kid? That would make an impact.
But Mr. Watkins, how does that, like, what broad objective do you want to see here? Because that's a very specific legislative ask that, again, we're going to talk about that at our next meeting. And I want to keep us in our lane.
At the last meeting, it wasn't really explained. It was just a no on arrival, which I would expect, but this is to restore the patient's rights in the enforcement process. Right now, they don't have a right. Right now, whatever we say, we can say without a guarantee. I can tell.
So, Mr. Watkins, I know you feel strongly about this issue, but what would the board's objective be here? What would the board be trying to accomplish on a, broad-based objective basis? We can have this discussion about your specific proposal about that specific statutory code section at our next meeting, which is it will be on the agenda, not that specific section, but our ideas will be on the agenda for discussion, and what we want to include in our 2023 legislative proposals. But this isn't the right place to have the debate about whether or not that specific proposal is one we want to advance or not.
So here's my action. I would like to see a change to Section 2330. And my issue here is to restore the legal rights of patients. That's it. No backstory, nothing.
So, Madam President, could I ask TJ a question?
Yeah.
Mr. Watkins. So under the first under the first action there, Mr. Watkins, consider possible statutory changes that would bring more transparency or could bring more transparency to this enforcement process. does that not address, I mean, couldn't this other thing be included in that? Where
No,
you're
actually it can't. It can't. I've gone through this. It cannot do that because that possible statutory change will be affected. 2330 guides all of them. It's actually central to everything that we do, how we receive information and how information is being presented. And right now, with the lack of information about patients from the get-go, presents a problem. So it is transparency, but this is actually the overarching section that informs all of the others. And that's why, I know this is not an easy ask, it's not anything, but nothing that we're going to do here is easy.
I just don't think in our strategic plan that this is the right ask. This is a very specific topic we need to debate as a board at the right time. The right time is actually when we're talking about our legislative asks.
So here's a question to that then. So if in the strategic plan we want to achieve an objective in the next 5 years, is restoring the patient's right not an adequate enough ask? I'm asking.
I think I'd like to make comments. Randy, the statement, the patient's right, to me is overly broad, and I don't know exactly what right is not being enforced. I mean, I would need more than just the patient's right. It's very, very broad.
I can break it down for you if you want to know the detail. The right to be informed, right? Do what is happening in the process. The right to inform, the right to be consulted when anything happens in that process, the right to amend their statements. If the doctor's presenting information, why aren't the patients afforded the same right to give new information or push back on that information? Because the doctors afforded all those rights. They can change their statements a couple of times. Also, medical records that is available. Here, this falls also under that section. Well, medical records that the patients provide to the board, do that have any credence, or is it considered less of a if those statements, those medical records differ from what the doctor presents?
I'm sorry, I have to stop us here. We're way in the weeds on all these details with various things that are coming up that we've actually talked about before at our meetings. We're going to talk about again. And so if we want an objective like bring more transparency, I mean, restore patients' rights is a very broad term. If that's what the board wants us to evaluate how best to restore patients' rights in the enforcement process and then come back with proposals, that would be more appropriate than where we're at in the weeds on the details of specific proposals, which one, we haven't agendized to debate today, and two, would require a lot more time for us to have to debate. And I just worry we're straying very far away from what we need to accomplish today.
Oh, I just wanted to explain that to Randy.
This is the facilitator. If I can interrupt you all, I apologize. We are getting too much in the specifics here. But first, I would like to confirm, Watkins, what section was that? 2330?
Yes, 2330.
Okay.
So for Randy, the response and the drill down is helpful, and it's the kind of stuff that would seem would be massage complaint liaison unit, et cetera, et cetera. I mean, I don't think we should throw them away. Again, I'm just not sure it belongs here.
What about the action being evaluate additional opportunity for patient participation in the enforcement process as the issue?
We've done that before. We are talking through this. When you talk about liaison, when you talk about any of that, that doesn't confer a right to a patient that is actually an enforceable legal right. You're talking about the board extending them a generosity. And a generosity is not a legal basis for them to have a claim on this process. And right now, they don't have a claim on the process. That's my concern. We can do this all kinds of different ways. Right now, the reality is that a doctor has certain rights that are very much protected, and the
Point of
patients
order.
have close to zero of those rights. I would like to see a more equal playing field with regard to that right.
Dr. Thorpe?
Well, you know, Mr. Watkins, I agree with your sentiment, but I think that we are, again, this is debate that we should have as a board. It's not, this is not part of the strategic plan. The strategic plan is these overarching themes, and I think transparency is a very, very good overarching theme. But these specifics we need to debate as a board, and I would speak against this addition completely. I'm totally against this. So including it under statutory changes that bring more transparency, I think that's that's all part of the same thing.
This is a facilitator. Sorry if I may jump in and interrupt. I would like to hear from more board members, so I can see, get a sense here. What if, Watkins, I see that you are requesting a specific issue here. Could it be broadened up to perhaps evaluate patients' rights in the enforcement process, and the why would be something like, I'm not sure, but it's leaving it more broad. That way it can be addressed and evaluated and addressed in different ways. Would that satisfy the other board members?
This is Jim Helzer. I would be in favor of considering an objective to increase patients' voice in the enforcement process. Since Section 2330 refers to the ability of the board to consider statements made by the patients during that process.
Okay, well, Watkins, what do you?
Well, you see, this is getting, why this is specific is because I've already narrowed it down, that this is the route that speaks to all things transparency. And since this is the way we're requesting a legislative change that will take about 5 years to enact, it is an appropriate request for this forum.
But Mr. Watkins, that's the point. We all haven't reached the same conclusion you have. We need to go through a process whereby we actually decide whether we all reach the conclusion you reached. We're a board, right? And so you can make this proposal. I haven't reached the conclusion you have that we have to change this specific code section, frankly, because I haven't studied it the same way that you have. So we've got to get to something overarching where we can evaluate this.
So let's evaluate it. Let's allow everybody an opportunity to evaluate what that means. I would be open to that. That's fair.
This is Ryan Brooks. I have a quick question for you. When you say restore patients' rights, were these rights that were granted at some point in time but taken away?
Yeah. Yes. You see, what happens at the front end, Mr. Brooks, is that the minute the patient goes and files a complaint with the medical board becomes the complainant.
No, that's not my question. My question is not the process. When you say restore, are you saying that these were rights once granted to the patient that at some process during the legislature or during regulations, we took that away?
The correct word would be ceded. Then, at the front end of the process, someone incurs some medical issue and they cede the right to the board. And after that right has been ceded, right, to the board, the board do not require legally to have any more communications with them after they take that statement.
So we're not restoring a right that was never granted. You're trying to change the process and how we can include the patients for better transparency. Is that correct?
Well,
I understand the process.
They had the right. They ceded that right without fully knowing what that meant. It meant being completely excluded from the process. And so I'm saying, why I was using the word restore is because they are still the original complainant. but they ceded that right. A better word would be they've ceded that right.
Well, so I think we need to think about what different rights, what different processes exist for what different purposes, right? I mean, we're the Medical Board of California. They haven't ceded their right to sue that physician separately, in a civil proceeding. They haven't ceded their opportunity to participate in a criminal process, right? But we're a certain type of agency with a certain type of statutory reach. If we're going to consider changing that statutory reach or opening up these opportunities, I really do think we need to have a further conversation, not in today's meeting, about where those opportunities are.
Yeah, and I'm going to just be my last comment. And I'm going to agree with the point that TJ's making here, but I don't feel comfortable because I don't know the section that he's referring to. And I don't want to make an informed decision, because if we're going to do it, let's do it right, right? Let's, have that discussion. Let's figure out the different areas in which we need to improve for transparency. I don't want to just agree to what TJ is saying, because there might be 5 other, things I've left out, or you've left out, or another board member has left out. And I want to make sure we get it right. I've always been told you can do things 1 or 2 ways. You can do it right, or you can do it right now. And I'd like to get it right.
Honestly, I'm not expecting this in a right now situation. I'm just bringing it back up because it was bombed out the last time. And it's that important. So we can continue.
This is a facilitator, so should we delete the notes that we have here for the third row, or refine it more, make it more broader? Board members?
In a prior discussion, you kept notes that could be used by board and staff as they thought about a particular goal. And so I would say, whether it's, I don't think it should belong in this section. I agree a lot that's been said in that regard, but I think that clearly staff should use these examples as part of what we look at when we have further discussions. That's my comment about it.
I think we can go back to what Dr. Helzer's proposal was, because I thought it was a good umbrella, which would be evaluate additional opportunities for patient participation in the enforcement process. And then I'm just using the language that exists here to determine if,
maybe incorporate that into the first line, or the first goal, possible statutory changes that could bring more transparency. Maybe that could be.
That's fine.
Broadened out a bit.
You see, what's interesting for me is that participation doesn't confer right. But if you want to, if this is the point today, then this is the point today, and we'll expect more information.
So,
what I don't even understand what that means. Participation doesn't confer, right? What does it confer?
Well, here's the deal. In terms of participation, if that participation is not founded on a legal basis, it does not confer a right. If we just give it as, here's a liaison that works through the board, that can end next week if we run out of money. And that's what I'm saying. I want it to be as solid as the doctor's rights on the other end of it, because then there's equal participation in the process. That's my fundamental position on this, because that's what's missing here.
Okay. Where's the board headed with this? Erin?
Ms. Lawson?
Yep.
This is something that has to be debated in a different forum, because there are so many considerations. An example, the standard of care has to be established by expert testimony. And so if a patient's statement disagrees with expert testimony on standard of care, what does the board do with that? That's all part of this consideration. That's part of why I believe that statute exists, that statements
after a matter is closed can be considered by the board to inform policy, but not to determine penalty, because many of the patient statements are members and staff take them to heart, but how does that translate into discipline? The board is not allowed to impose discipline beyond what's necessary to protect the public, or it can be subject to action at the superior court level or beyond. So I just raise this because there's a lot to discuss here and consider and debate. The board can't make plaintiffs or patients whole. That is for the civil courts, but exploring ways to be more transparent is something that is actively being considered.
Okay.
So here's a
Just
question.
So TJ, the debate for this has to happen in a different forum. So we're not going to talk. We can't spend any more time debating this today, or we're not going to complete the strategic planning work we actually need to do. So I think we should leave this as the facilitator just drafted. Evaluate additional opportunities for patient participation in the enforcement process to determine if changes need to be made, and then that'll set up an opportunity for us to have a further debate on this particular issue. Does that work for everybody?
Thank you.
Okay.
This is a facilitator. I would like to share that once the strategic plan it will be presented in another board meeting for your review, for your edits. That's where you can edit, you can add or add an objective, change the wording, and approve. But also, even after it has been approved, it's a living document. You can always go back and add an objective, take out an objective. So just keep that in mind if you later do have this particular discussion in a board meeting and hash it out, then you can always add it to the strategic plan.
Okay.
Board members, and I know that you asked not to have any more discussion, but wanted to make sure all board members were okay, or most board members were okay. If there's some consensus with this last objective, that evaluate additional opportunities for patient participation in the enforcement process to determine if statutory changes need to be made. If I can hear from other board members who haven't had the opportunity to speak and would like to speak.
Hi, this is Michelle, and I concur with the evaluate, and I also want to acknowledge the issue of patient right being very broad, and if there needs to be draft language, there is a Bill of Patients' Rights, and I think that's going to be a much broader discussion and one that we shouldn't lose, but I'm perfectly okay with this last entry.
Okay, you mentioned patient rights. What we have here is patient participation.
No, I don't want patient rights. I'm suggesting that that's a much broader topic.
Oh, I see.
Right.
Thank you. I apologize. Okay. Any other board members? Any additional objectives any other board member would like to suggest?
Sean, can we open this up for public comment? I don't think we've had public comment on legislation and regulation yet.
Madam President, I have a quick question for clarification on the legislation piece, please.
Sure.
So last time we went to sunset, we had our different requests, kind of urgent, middle, and kind of low hanging fruit. For the ones that were not addressed in sunset, for the next sunset, do we go back and evaluate the ones, we didn't get, or has that been done already? Do we need to put that down as something that we need to go back to?
We had that conversation at our August board meeting, and we reaffirmed the priorities that we did not get accomplished in the 2022 cycle. And so those are going to be showing back up in the sunset report and in our, on the agenda at our next meeting is either part of new proposals or as part of our sunset report for us to have a conversation about again. But we did reaffirm those. We didn't make any real changes from what we already asked for.
Got it. Thanks for clarifying.
Yeah.
So you want me to open up the public comment now?
Yes, please.
Okay, here we go. So the raising hand feature in the Q&A window has been activated. Anyone wish to make a public comment, please go ahead and type anything in the Q&A window or raise your hand and we'll call on you. If you are on a call-in only line and you wish to make a public comment, you can press *3. I think I said the wrong thing earlier saying *6. So *3 will raise your hand there, and then *6 can be used to unmute yourself when that time comes. So first up here we have Annette Ramirez. Annette, I'm going to go ahead and send you that request.
Hi, can you hear me?
We can. Yeah, please go ahead.
Hi, again, I am Annette Ramirez from Manhattan Beach, California. I am a volunteer with Consumer Watchdog. To Mr. Watkins' point, thank you very much. I too want to see changes made to Business and Professions Code Section 2330. This is the one way that we can see the enforcement process more balanced for doctors and patients. I also want to see changes made to give complainants like mine an opportunity to be interviewed by the board before a complaint is dismissed. I really want to hear from the board and staff how, in my case, that the loss of 4 limbs and life in a wheelchair does not warrant an investigation. Additionally, I want complainants to have the opportunity to submit a written statement to the Deputy Attorney General overseeing the case. I want this statement to have equal weight to the doctor's information. This is the missing piece. This will ensure that the patient is equally represented in this process. It will also make sure that the doctor has due process and that the patient has due process. Thank you very much.
Thank you for your public comment. Up next here we have Eric Andrews. Eric, you should receive that prompt on your end. $30 remaining. Thank you for your public comment. Next up here, we have a call-in user on a 561 area code. Should be receiving that prompt on star 6 to unmute on your end.
Yes, hello?
Yeah, we can hear you. Please go ahead.
Oh, great. Yes, so this is Dr. Reed. It's Black Patients Matter. We are not with Consumer Watchdog. Consumer Watchdog has never reached out to us. We are patients of color. At meetings, they never talk to us. They pretty much ignore us. And we don't read from a script. We are independent thinkers. We advocate for African American patients and minority groups. So I just want to thank the medical board. It's a very lively conversation going on, discussion. It's just important to, maintain communication. I'm very, very concerned about Ms. Lawson. I think, Ms. Lawson, if you review the tape, some may say that you're shouting at Black folks. So that's not appropriate to shout at anyone. I do think you need to check yourself. I do wonder if perhaps it may be time for Ms. Lawson to step aside. This has really become a very hysterical meeting, and it doesn't need to be. So thank you for letting me speak. Thank you.
Thank you for your public comment. Up next here, we have Denise Johnson. Denise should be receiving that request on your end.
Good afternoon, Madam President and members of the board. Once again, my name is Denise Johnson. I live in Tracy, and I'm a volunteer with the Consumer Watchdog. Transparency. As someone whose complaint was dismissed at the Central Complaint Unit, I know what it feels like to have no answers, nothing but a cold, harsh form letter. I want all the records and every document created during the CCU process available to me as a complainant upon my request. The complainants and families whose cases were closed at CCU deserve answers beyond a form letter. I want to see why my case was closed. If the board was truly asking for more transparency and accountability, I ask that you take this on as a legislation as well as enforcement objective. We are requesting a change to the Business and Professions Code 2330. Complainants' families must be given the opportunity to provide a statement to the to the Deputy Attorney General assigned to their case. The statement should be considered by a panel of the division or other board for purposes of making a decision on that case. The statement can also be presented in person by the complainant or family in front of a panel or board. The statement may be considered by the division or the board after the case is finalized for the purpose of settling general policies and standards. We are requesting that the complainant and family member be interviewed by the board before a complaint is dismissed and give the complainant an opportunity to provide more information and respond to a case beyond the initial filing of the complaint. Notice of doctors under investigation for serious cases. Patients have the right to more information than you provide us with on the physician profile. We should have the right to know if our doctor is currently under investigation, especially if that doctor is a repeat offender, is already on probation, or has had license suspension that we are not aware. We are calling on the board to post a physician profile that a doctor has a complainant that is under investigation when the doctor is a repeat offender, is currently on probation, or has a substance abuse problem. We're requesting that you report on the profile directly under the physician's name the following. If the license has ever been suspended. If the suspension has been completed, then list license suspension completed and the year. If the license has been disciplined, but the doctor is appealing the judgment, then you would list the discipline reached, probation, currently under appeal. If the board has received an 805 report, then you would list the 805 report, loss of hospital prisoner, an 805 report unsubstantiated. If you truly want to work with the transparency and accountability.
Thank you for your public comment. Up next, we have a call-in user from the 661 area code. You're receiving a prompt to press *6 on your phone to unmute.
Hello.
Yes, we can hear you. Please go ahead.
Thank you. This is Susan Shanese from Bakersfield, California again. I am the co-founder of Hospital Watchdog and a volunteer with Consumer Watchdog. At hospitalwatchdog.org, we speak for the patients, but we also speak for the nurses and doctors that are good, and which most are, and the ones that are seeking for improvements in healthcare, because that's what we all need. I'm going to skip my story right now because really, after listening to the objections regarding the complainants having the same rights as physicians in the due process investigation, it's very disheartening. I think that individuals might just question themselves if they don't see why patients deserve, or the complainants deserve, the same rights as the physician. They might just have too much of a conflict of interest to hold that position. And I'm not pointing the finger or trying to be personal. It's just kind of what I've observed and the way I feel. I think, to be fair to the complainants, changes do need to be made to the Business and Professional Code Section 2330. Complainants must have a due process just as physicians do. Why not? Is there discrimination here? Complainants must be given an opportunity to provide a statement to the Deputy General who is assigned to the case. They must also be presented to, they should be able to present the complainant statements in person in front of a board panel. It must be considered for the purpose of making a decision on and voting for the case or complaint. These statements must also be considered by the board after the case has been decided for purposes of settling policies and standards. Again, I ask you, please allow due process and the same rights for the complainants and medically harmed patients as you do for the physicians. Thank you. I would also like to speak a minute about expanding the patient's rights to know, to include all egregious death and serious bodily injury harm cases. There must be more specific guidelines in place to ensure that the doctor on probation is adhering to the patient notification requirements of their probation, and a way for the public to know that. Thank you again. Good day.
Thank you for your public comment. Next up here we have, let's see, Christina Hildebrand. Christina, be sending you that request on your end.
Hi, Christina Hildebrand. Can you hear me?
We can. Please go ahead.
Hi, Christina Hildebrand from A Voice for Choice Advocacy. We educate and advocate for informed choice and transparency of what goes into your body. The legislative process is one that we are incredibly involved in, both putting bills forward and opposing bills that come forward. One of the bills that I would like to see you, and maybe it's actually a more general bill rather than just revising AB 2098, which was the misinformation, disinformation bill for physicians. You were very for this bill, but the definition of misinformation there does not define standard of care or contemporary scientific consensus. We have had discussions, or you have had discussions on the board. I bring it up every single board meeting on standard of care and how standard of care, what you see as standard of care and define as standard of care in board disciplinary hearings does not mirror the latest information. Interestingly, on AB 2098, the governor did in his signing statement say that he did not think this would have a chilling effect on physicians and surgeons who need to be able to effectively talk to their patients about the risks and benefits of treatments for a disease that appeared in just the last few years. However, I'm confident that discussing emerging ideas or treatments, including the subsequent risks and benefit, does not constitute misinformation or disinformation under this bill's criteria. We have seen over and over again with the medical exemptions, the vaccine medical exemption cases you have, that you do not take into consideration emerging data. Many of those medical exemptions were written based on genetics, based on research that's been done in the last 5 years, and you have disciplined those doctors. So I would like to see a bill that defines standard of care. If you go to the Knox-Keene Act, there's a list of insurance qualifications for prescribing medication. Something like that would be great. If you need information, I'm happy to give it to you. I also agree that you really should know what 2330 says, given that it is the crux of the disciplinary action and the enforcement action, but you have to involve patients. There has to be a change in it that allows a patient, the same way as in a jury hearing, or a civil court case, where the patient can give their side of the story and not just be represented by the medical board, because you don't do a good job at it. And finally, there was an article that was put out this week that said that patients are not getting the care that they want, and doctors are getting tired out because of all the electronic health records. I would ask you, one of the things that you discipline a lot on is not having good enough records, but the electronic health records are throttling our system and not creating good patient care. So I ask you to have legislation that looks into that, please. Thank you.
Thank you for your public comment. Let's see, next up here we have Tracy. Tracy should be receiving that request on your end.
Good afternoon. Okay, I too agree that section 2330 should be changed. Complainants must have the opportunity to provide a statement to the Deputy Attorney General assigned to their case. These statements must be taken in consideration during the decision-making process and the vote. These statements must have equal weight to the physician's information. I do believe if this provision was in place when Celeste Ortiz case was being reviewed, and if the graphic details of Arthur Park yanking out this young mother's placenta, perforating her cervix and uterus, and watching her hemorrhage and die in front of him, I have a hard time believing that this board would be heartless enough to grant him probation once again and give him the opportunity to harm and link to the deaths of not only my daughter Demi and my grandson Malachi, but multiple young mothers. Public reporting on this physician's profile. I believe in this case that it is especially involved in a repeat offender, a doctor on probation, or substance abuse. A complaint filed should be noted on the physician's profile right under the physician's name. A doctor with criminal charges should have those specific changes spelled out on his physician's profile. If a doctor's license had been surrendered or revoked and the provider is reapplying for license, it must be noted on the physician's profile. License suspensions be posted on the website once completed, listed, and license suspended, completed, and year. Prior to my daughter's pregnancy, her doctor was Dr. Jason Hollowell. Well, we saw on the news that Dr. Hollowell's license, and he was in trouble because of sexual misconduct. Both my daughters left his practice. In need of another OBGYN, my daughters changed to another doctor, just as grievous and even more. I share this with you to show you how to help to prevent repeat offenders and the harm in my community, especially surrounding maternal health care. We need more information to save lives. What if this was your daughter and your grandson? How would you feel? Would you be fighting like I am?
30 seconds remain.
Or would you just sit there and do nothing? Because no mother deserves this. No family deserves to go through what we have. And we continue daily. We carry this night and day. It never leaves. Thank you.
Thank you for your public comment. Next up here we have Christina Hildebrand. Christina, you should be receiving that request on your end.
Sean, I believe she's made a comment.
I'm sorry, I didn't put her hand down. Sorry about that, Christina. And so that would take us to Monique Himes. Monique, you should be receiving that prompt on your end. Try one more time here, Monique. Okay, Monique, it looks like your line's open. Are you there?
Hello?
Yes, we can hear you.
Okay, perfect. My name is Monique Himes. I'm from Bakersfield and I'm a volunteer with Consumer Watchdog. Panel A and Panel B hearings, all Panel A and Panel B hearings must be asked. Complainants must be given the opportunity to speak at panel hearings to offer a statement or respond to questions. Complainants must be notified when their doctor whose license was surrendered or revoked reapplies for their license and must be given the opportunity to speak at their panel hearing. Changes must be made to Business and Professions Code Section 2330. Complainants must be given the opportunity to provide a statement to the Deputy Attorney General assigned to their case. These statements should be considered part of the record during the decision-making process and the vote. The complainant statement must have equal value to the physician's information. This is the only way that we can give some balance to the enforcement process. Thank you.
Thank you for your public comment. Next here we have Marion Hollingsworth. Marion, let me send you that request. Should be on its way.
Hello?
Yep, your line's open.
Okay, thank you so much. Hello, my name is Marion Hollingsworth, patient safety advocate. It's upsetting when the rights of patients to their own complaint is usurped by the board. I'm talking about 2330. To not have any access to how our complaints are proceeding with no chance to counter what the doctor is saying is totally unfair. It gives all the power to the doctor. To say patients still have the right to civil complaints is a slap in the face. Most of you have no idea what it's like to grieve or heal while you're desperately trying to find a lawyer to take your case within a year. In my case, your investigator told me that there would definitely be an accusation, and she would keep me informed. Instead, there was a private settlement where the doctor was able to plead down a death case to a PLR, a simple reprimand. I was just sent a brief letter informing me of this change with no explanation. This investigator also told me the DA, my local DA, would post a reprimand, but that the DA's office was short-staffed, so it would take a while. I contacted that DA's office and was told that not only were they not short-staffed, but that the board posts the reprimands, not the DA's office. So I was told a bald-faced lie. Then your executive director at the time told me the PLR would be posted within 6 months, and it turned out to be 18 months. She said this doctor would have to take some classes I was never told about. By having transparency, I would have known more about how my case was handled so that your investigators would not have been able to lie to me without any accountability. I can even give you her name. She's one of your supervisors now. And this is why we need a change in 2330. We need a law to protect the integrity of our cases, to keep us informed, and to ensure that we won't be lied to. We at least have the right to know how our cases were handled thoroughly and not summarily dismissed. And I also agree that there should be an audit so we can find out what else we have been lied to about. You board members always seem to forget the patients. You only focus on the rights of the doctors. It's time you put your mission statement to use and actually protect us consumers. Thank you.
Thank you for your public comment. Next up, we have Susan Lauren. Susan, let me send you the request. Should be receiving that on your end. There you go.
Okay, thank you. I came back into the meeting in the middle of what TJ was saying, and I've been listening since, so I hope I'm on track. I'm Susan Lauren, and I am an independent patient safety educator and researcher. I am a victim of surgical assault and scams and cover-ups. And victim is a noun. It's not a way of life for the person. I agree that Section 2330 needs to be changed. I support there being an audit. Beyond that, records, the records originally, especially in ambulatory centers, need to be a co-authored event, because what's happening is the doctors lie in their records, they fake their pictures, they alter their pictures, and you will never get the truth. In my particular case, the truth is all over, even the lied records. And still, your board dropped the ball on this. Still, I'm reading online of other people who claim to be harmed by Saul Berger, but bigger than that, this whole entire field that I've been talking to you about. Title 16 of the CCR does not meet the current standard of care. It doesn't meet contemporary scientific consensus. And if you want to give patients coming behind me the true informed consent, they need to know what's going on with me and all the other men and women and teens that I know about, and that you're throwing their cases out or they're not even coming to your board. People like to say that most doctors are good, but there are no statistics to actually show that's the case with plastic surgeons, and that is not at all what myself and the other victims have found. And I have done extensive research. You can look up, like I did, the California Medical Association plastic surgeons, or those listed on Malcolm Lesavoy's resume, or any of them. And if you look hard enough, you're going to find some woman somewhere crying out that their life was ruined by this doctor and that they were treated like crap after. It's the same story. The civil complaints, that's what you think we should have, because in my civil complaint of battery, your expert, Terry Dubrow, used his sway as a medical board expert to lie to my jury. How many times do we need to talk about this? A physician has a duty to inform a patient of material facts. It's something that a prudent person would agree to. You look at my case, there's nowhere that I agreed to any of this, to have my body parts removed, and you did nothing. So there's more to say, but I want to support Annette and Tracy and just all the activists. It just hats off to all of you, and thank you.
Thank you for your public comment. Line closed there. Next up, we have Michelle Montserrat Ramos. Michelle, let me go ahead and send you that request. Michelle, you there?
Yes. Good afternoon. I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. I agree with everyone else that Business and Professions Code Section 2330 must be revised. Patients must be identified by name in the accusation in the DAG memo instead of just using initials or numbers. Complainants must be given an opportunity to provide a statement to the Deputy Attorney General who's assigned to the case. These statements must be considered by a panel of the board for purpose of making a decision and voting on these cases. I also want to see changes made to give complainants like me an opportunity to be interviewed by the board before a complaint is dismissed. When I filed a complaint, as complainants, we were never told that we no longer had a right to our complaint. We were never told that our death complaints now belong to the state. I think you either have to give patients rights in this process, or you have to be honest with complainants and patients that going through this process is meaningless because you have no right to communication. You have no right to provide the board more information. If you investigate your case on your own and file complaints with other departments and agencies, the board can ignore that information when you try to provide additional information. We know there is a deep problem with how the enforcement process is working. It is not working for complainants. It has not worked for any members of my team except for maybe two, and one of them, I had to intervene and work with them and organize a campaign for them. I agree that this is the place where we need patients' rights. Revising Section 2330 will add balance to the enforcement process. It will ensure that doctors have due rights, and now patients will be allowed due process as well. Giving rights to patients will not take away rights from doctors. All we are asking for is a fair process. If your loved one died needlessly, like mine did, or your child died tragically, you would want the same. Complainants must be notified of all hearings and be given the opportunity to participate in all hearings, including Panel A and Panel B hearings. At a recent panel hearing, I heard a patient's reputation be destroyed by a doctor's lawyer without her knowing and without her having the ability to defend herself. This doctor was accused of sexual misconduct at his pediatric urgent care facility, and he received no discipline for his actions.
30
This was
seconds
a
remaining.
prime example of a case where the complainant must have input into the process. Complainants must be notified when a doctor whose license was surrendered or revoked reapplies for reissuance of their license and must be given the opportunity to participate in the hearing. Thank you.
Thank you for your public comment. Next one we have here is Kimberly Turbin. Kimberly, let me send you that request. Should be receiving that on your side. There we go. Kimberly, I see your line opening.
Hello, my name is Kimberly Turbin. I'm from Los Angeles and I'm a volunteer with Consumer Watchdog. I want to change to a business and professional code 2339. We need a change in a way complaints are managed when it comes to misdemeanors involving alcohol and substance abuse. The use of prescribing and or administrating to themselves of any controlled substance or the use of any dangerous drug specified in section 4022 or of alcohol to the extent that is dangerous to the doctor and or person in the public, or to the extent that such use impairs the ability of the doctor to practice medicine safely, and one misdemeanor or any felony involving the use of consumption or self-administration of any substance referred to in this section constitutes unprofessional conduct. We cannot continue to allow multiple violations of the uniform standards to slip past the public. Substance abuse is taken seriously in any other profession. We are dealing with life and death in this profession. The change will protect the health of the profession as well as the health and well-being of their patients. Notice of doctors under investigation who are repeat offenders, including egregious cases. I suffered medical battery during the delivery of my child, which led me to become a maternal health advocate. I have taken personal interest in the maternal mortality crisis, especially the crisis occurring in Bakersfield and Kern County. Prior to one of my fellow advocates losing her daughter to maternal medical negligence, her daughter had given birth to her first child who suffered lifelong harm when Dr. Park delivered her baby. Years later, her daughter was expecting another baby and had complications near the end of her pregnancy, and Dr. Healywell as her doctor. This family had no idea of the background and past history of Arthur Park. Years later, this young mother would die under the care of Dr. Healywell, while he was on probation for harming multiple women and sexual misconduct. I share this family's tragic story to show how prevalent this harm is and how many repeat offender doctors are involved. We need to provide pregnant mothers more information on the physician's profile. You can do this by specifying complaints that are being investigated on the physician's profile for repeat offenders in cases of egregious harm or death. Thank you. And Sabrina De La Rosa should be here. Unfortunately, she has died.
Thank you for your public comment. Next up here, we have a caller from the 310 area code. Caller, you should be getting a prompt on your end to press *6 to unmute. There you go.
Hi, can you hear me?
We can.
I'm
Please
sorry,
go ahead.
I'm in the car. Ironically, with my husband on a way to a convention or a retreat for gastroenterologists. So, listening in. And I wanted to just make a comment on, my name's Wendy Connect, by the way. Sorry about that. I want to agree with the other callers that Section 2330 must be revised. It is really patronizing to tell patients that they have a right to make a statement after the discipline happens when we know none of this really affects future policy. If that were actually the case that patients' voices mattered, you would allow us to make comments to the Deputy Attorney General in charge of our case, and as well in person at the time. We should have equal consideration in the process. But I'm really wondering why even the board members do not have access to all of these documents. Again, you have to wonder about the relationship between the AG and the...
Wendy, we're having a really hard time hearing you. I believe because you're driving, you're losing reception. Okay, I think it's safe to assume here we've lost Wendy. Still checking here, but at this time, Ms. Lawson, I don't see any additional requests.
Okay, we'll bring it back to the board, and I guess the facilitators from Solid can maybe talk to us about whether we want to add additional legislation and regulation objectives.
The moderator, sorry, the facilitator. Any additional objectives, board members?
Are we ready to move on to outreach, which is the final area? Yes.
Yes.
Thanks. Let's do that.
All right. Uh, Elizabeth will be sharing her screen shortly. And then we'll get started on our final goal area, which is outreach. So if Elizabeth could be given, yep, perfect. Thank you.
Yes.
All right, so the final goal area is outreach. And we do have a summary of weaknesses like we did for the previous goal areas, if you'd like to take a look at that for a moment. And so can we see the list of weaknesses, please? Thank you. So again, these are just weaknesses that were listed by stakeholders that took the environmental scan summary. And there are some suggested objectives as well. All right. And it looks like we have one objective that was, or issue that was carried forward to outreach. Would anyone like to suggest an action verb, or how do people feel about creating an objective that addresses this issue?
Michelle, it looks like you're on mute, but I can see that you're trying to speak.
No, I was thinking of the action. You're
Oh.
either, I was thinking of the action word of, no, is it scheduling? Is that how you're going to get more stakeholder meetings? And I think this is, yeah. And why do we want to do that? Because we want to hear from members of the public and other stakeholders, and hopefully have a future dialogue. So all parties, similar to what was mentioned before, all parties have an opportunity to hear each other. That's important.
Thank you.
I guess I would add that I think we need to put some thought into designing these meetings and what these meetings look like and how we conduct the outreach, because there are lots of different avenues to do that. So just scheduling them, I guess, feels incomplete to me, that we should have.
It is. It's to design it. I agree with you.
Okay.
Create the structure.
Okay.
And when and how.
I would say structure, format, and topics.
Okay. Okay, how does that look?
I think that the stakeholders are the public, but I just want to be sure, and I don't know how the colleagues on the board feel, but I just want this, it's not the public against other stakeholders. I think it's incorporated unless,
Yes.
and we're doing it for what reason? For public protection. That's what we're having these conversations about. That should be our number one reason for having these conversations.
Yeah, I don't want the stakeholders to be limited, right? I think about it in the context, for example, of the update to the pain management guidelines that we have underway, right? And that's a particular stakeholder group. And obviously it's broad enough that those meetings are open to anyone who wishes to participate and join in them. But I don't want to limit ourselves to one stakeholder group or another.
Yeah, I was going to suggest using the word interested parties.
Yeah, I like that better.
I like
Okay.
that.
So to hear from interested parties. Thank you. Other objectives?
Well, this is Dick Thorpe again. I would just
Mhm.
say under the why, to encourage bilateral communication with interested parties.
Okay. Thank you. Anyone else regarding this first objective or a new one?
I have a new one.
Okay.
It's Randy. So this involves education
Okay.
of medical students and physicians in training
Okay.
regarding the mission of the medical board and
Okay.
their responsibility as relates to public protection. I'm trying to, what I want to get to is, and I'll ask for some help. It
Uh-huh.
really is to educate those in training about
Okay.
their responsibility they have for providing
Okay.
care and as it relates to our mission of
Okay.
public protection.
Okay. And then the benefit of that or the why?
So this is a reduction of patient harm.
Okay.
Um, um, One, I think this makes a better physician.
Okay.
But man, I would take other comments, amendments on this very, very important one.
Okay. Other board members?
Well, I would just expand this to include physicians in practice as well, because I think it's unfortunately it's not well understood by many physicians in practice what our responsibilities are, and
Okay.
I think it would be medical students, physicians in training, and physicians in medical practice and active, and active practice.
Okay.
And I mentioned the medical students and physician in training because we really want to get those folks early.
Yeah, I agree.
Okay, so looks like we're going to change the medical students and then comma physicians in training and then active physicians, or you could just say licensees. And it was physicians in training. Yep, perfect. Thank you. All right.
So I think another topic and something we've heard over and over again
Mm-hmm.
is we need to focus on prevention.
Okay.
And and so the goal is to reduce patient harm,
Okay.
education, um, education via newsletters,
Okay.
internet, social media, training, etc.
Okay. And when you say on prevention, do you mean on prevention of malpractice or violations?
Well, more work on on prevention, how to reduce patient harm.
Okay. So focus on prevention of patient harm
Correct.
issue. Okay.
And it goes back to the mission and the goal of why we're here as a board.
Hmm.
And this is something we've heard over and over through public comment. So I thought this was very important, and I agree with it.
Okay. Other board members?
Lori here.
Go ahead, Lauren.
Thank you. One objective I was thinking about is around improving access to resources, whether it's training materials, documents, or just improving the accessibility, whether that accessibility is the format of these materials, if it's a technical issue. I know in some instances, whether folks are on a Mac or a PC, that might provide some difficulty in accessing materials. So something along those lines.
Okay. So maybe on the next slide, something about improving accessibility or improve accessibility.
Ms. Lubiano, can I ask for clarification on what you mean? Are you talking about the board's website, which already has to be compliant with ADA requirements?
I think that's part of it. My suggestion is a broad one in that in doing the outreach, whether it's social media or it's documents or trainings, that we think about making it as accessible as possible, to whoever, if they from a disability standpoint or just ease of use and presentation, something like that. That's what I'm thinking of.
So to clarify as well, as Ms. Webb was kind of reading my mind. So whenever I guess, is there an example perhaps that, you could share where you feel like we could improve? That might help as staff are kind of chewing on this after the meeting.
Located at 5399 West Centinela Avenue in the Ladera Center, Los Angeles, California.
So it sounds like.
Can we get everybody to mute their lines, please?
Yes, thank you. So it sounds like the idea is to improve the accessibility of outreach materials. Was that the intent?
Yes, of materials, resources, trainings,
Okay. And then the benefit or the why.
Is well, for ease of use and accessibility.
Okay.
I mean, I know I'm speaking really generally here, but whatever outreach that we're doing, I'm trying to think of ways. No, I don't want these minor roadblocks of, oh, because they're on a Mac or, they're on a PC, they're having trouble. So just
Mhm.
having this overall thinking that whatever kind of materials we're putting out there, if it's paper, if it's social media, whatever, that we think about making it as easy to access as possible and etc.
Okay.
Sorry, I'm not, I can't be more specific at the moment, but I think there's something there.
Okay.
So I'd
Madam
like to,
President, if
yeah,
I had another clarifying question on the previous slide, if I may, if this is
okay,
the right time for that.
sure.
If we could go back. Great, thank you. And I guess I'm not super clear, and maybe Mr. Brooks, since I think the focus on prevention of patient harm, could you maybe help me understand a bit, Mr. Brooks, the contrast between the educate, item number 2 there versus item number 3? I wasn't there's very similar goals they seem to be there, and so I don't know if there's some additional clarification on the distinction between those two goals.
Yeah, so I'll go back to my time at the 15 years in the Board of Pharmacy. We put out a monthly newsletter talking about you know the effect of alcoholism in impaired doctors and what that could do for patient harm into your license. We could probably do the same for here. We could also expand on the patient harm is it could be through the prevention could be through annual trainings, right? It could be through more educational, credits and points. And so anything that we could do collectively to reduce the number of injuries to a patient through, education, through newsletters, through seminars, through conferences, through public outreach, goes to the goal of who we are on the medical board. I don't know if that's any more clarity or if that's too much of the same under education.
I I just can't help but wonder if combining of those two, they I don't want to miss any distinctiveness that I'm not picking up on, sir. But if combining them perhaps makes sense, but I'll leave it to the board.
I'm okay. I mean, I don't, as long as it's there, if it's in, one bullet or two,
Yeah.
it's irrelevant to me as long as we focus on what the issue is.
And this is Trisha. I wonder if we can change the focus on prevention patient harm to an action item to go underneath the objective to educate medical students, et cetera. Would that be helpful?
That might be a feature of education is that focus on prevention.
Exactly. So during the action planning, that could be one of the tasks for that objective. And Elizabeth is making note of that. Thank you.
Does that work, Mr. Brooks?
Yes, absolutely.
Thank you, sir.
You.
I have one outreach item that I've been thinking about, and
Okay.
that is the action is to develop and create an online video course that was developed in conjunction with CCU, HQIU, and the AG's office. And what they will learn specifically is how to write a complaint, in the best way that the AG and the best way CCU, HQIU, and the AG's office want to receive it. And the goal of that is to reduce the amount of complaints that are dismissed at CCU for a complaint was incomplete.
Okay. So the online video course was on how to write a complaint.
Yeah, how
Correct?
to write a
Okay.
complaint,
Okay.
more compelling complaint or something.
Okay. And then you wanted that video course to be developed in collaboration with CCU, and was there
HQIU and the AG's office, because they know the most about
okay.
what it needs to look like, what it lacks.
Okay.
So I'd like to propose perhaps a final objective.
Okay.
But I think it would be helpful if you could scroll back up to board administration, because I know that we have an objective that relates to our committee work.
Okay.
And so it doesn't look like it's on this page. Yeah, so reorganize committees. I actually think there's something there that we can also include within outreach, because of the size of our board, frankly, because of the scope and reach of the work that we do. Some of the work we do is too complex for all of us to do in our quarterly board meetings. And I have been really, really pleased with the progress that we have made using that prescribing task force, right, to really dig in, facilitate communication with the public on that issue, help drive the change in a task force format, and then bring that back to the board, right, after it's really been vetted and there's been a lot of diligence and there's been a lot of that communication that, frankly, I mean, again, because of our size, we can't even get ourselves together, right? It's really difficult for us to even get a meeting and have us all available, but it's less difficult to get a committee or a task force. So I think that, I mean, in the outreach section, what I'd like to do is, I guess, analyze or review our committee and task force structure. And frankly, I know we have a board rules and policies or board rules and procedures handbook. I know I'm getting the name of that wrong, but even look at that to see if there are opportunities to improve our structure so that we, can better communicate with interested parties and build the trust that's going to be necessary, to continue to improve and advance the board. Because I just think we're missing some opportunities to work in smaller groups, and be deployed to go out and do the outreach and then come back to the, board in our quarterly board meetings. There just isn't enough time in our quarterly board meetings to do all the things we'd like to do and build all the trust we need to build.
Okay. And Christina, did we capture the why?
I think so. I guess I want to make sure committee and task force structure, and also our board, and maybe Carrie, you can correct me as to the precise name. I was trying to look it up and I can't find it. I have board rules and procedures handbook, but written down, but I don't think that's what it's actually called. Maybe it is.
The board member administrative procedure manual.
Okay, that's what I'd like to take a look at.
Okay. All right.
Thank you for that one, Christina, because we've gotten suggestions from our stakeholders about ways that we could potentially interact. And I think that potential changes may facilitate better communications, as you've already said.
Are we ready to open this up to the public for their input here? I'm getting some head nodding. Okay, let's do that.
Okay.
The Q&A window and the hand raising features have been activated for anyone wishing to make a public comment. Simply type your name into the Q&A window or anything, or raise your hand and we'll call on you. If you're on a phone line and you'd like to raise your hand, you can press *3. First up here we have Virginia. Virginia, you should be receiving that request.
I was applauding Mr. Brooks with his prevention discussion, and it was going really well until it was deleted. There's 100% difference between what he was saying and what you put it together as. Responsibility of the board does not equal patient protection. You did this whole thing. You have the vision, patient protection. You don't have a task force. You don't have it on any of your agenda items. You have like little things that will protect the patients, but you don't have like an overarching theme to protect patients, even though it's in your vision statement. So how are you going to prioritize this when it's not in your recommendations for the board to spend the next 2 to 5 years using their time and resources on it when it's absent from it? How's that going to work? That's my question. How are you going to protect the patient using prevention when it's not even listed in any of your things? I've asked several times during this meeting. I wasted all my day trying to get it added. And here we are at the end.
Thank you for your public comment. Next up here, we have Eric Andrews. Eric, you should be receiving that prompt on your end. Thank you for your public comment. Up next here, we have Christina Hildebrand. Christina, you should be receiving that prompt.
Hello, can you hear me? Christina Hildebrand?
Can, please go ahead.
Christina Hildebrand from A Voice for Choice Advocacy. We educate and advocate for informed choice and transparency of what goes into your body. I think this outreach, I know the medical board in the last year, maybe year and a half, has been really trying to do more outreach to, what was it, the word you used, in interested parties. But that's what you're doing. You're doing outreach. You're not doing communicating with us. The opioid one was a little bit better. I'll give you that. That was a better go at it. But when you have communication with interested parties, the same people show up at these medical board meetings year after year, after quarter, after week, after we are always here. And we don't get listened to. TJ Watkins, I give you, there are a few of you on the board that listen to us, but the majority just don't listen to what we have to say. We've been around way longer than most of you have doing this. And I just ask you, we know we have expertise. We have, our organization is in the Capitol day in and day out. Other organizations are consumer-based organizations that are helping people that are being harmed by your doctors that you're not disciplining, but yet you don't listen to us. You don't take our advice. You don't move forward with what we need and what we're asking. And I just, this whole outreach thing means absolutely nothing if you don't have your ears open and listen and make change based off what we're saying. Thank you.
Thank you for your public comment. Next up here, we have a call-in user from the 561 area code. You should be receiving that prompt on your end to press *6 to unmute.
Yes, hello, Medical Board. This is Dr. Lee with Black Patients Matter. We are not affiliated in any way with Consumer Watchdog. We've never worked with them. We don't read from a script, and we come to the table offering solutions. So in terms of mediation is going to be phenomenal. It's a game changer. Not only will it save the medical board hundreds of thousands of dollars, that money can be diverted to other sources, maybe for raises for those that are working behind the scenes at DCA, HQIU, enforcement, maybe for outreach, but it's going to be a game changer. And so the details of which, I would just defer to you all to further discuss. But what we're seeing really is a big difference in how lawyers and how doctors think. So in terms of law, there is lawyers, I assume, are trained to defend not their plaintiff, not the people that hired them, but to defend the Constitution, or in this case, to defend the business code or ethics or whatever is written in the books. And so lawyers think more in terms of black and white, guilty, not guilty, sentence, that sort of thing. As physicians, we are more about, we're like sculptors. We have to balance different organs of the system. We have to think holistically. We have to think about how best to treat the patient and not cause harm, that sort of thing. And so with that kind of mentality that physicians have, mediation is the solution.
30 seconds
Certainly
remain.
for lawyers, they would like guilty, guilty, not guilty. But that's not how the human body works. Thank you.
Thank you for your public comment. Up next here we have Susan Lauren. Susan, should we receive that prompt?
Hello. I wanted to echo every word that Christina Hildebrand said. And I don't know Christina, but I want to thank her publicly. I've been listening to her for years, and I know that a lot of us are not listened to. I listen to you, Christina. I hear you. It's unfortunate I'm not in the position to do something about it. Prevention is the number one priority, and anything we can do to focus on that, I support. Thank you.
Thank you for your public comment. Next up here we have Michelle Montserrat Ramos. Michelle, let me send that request. Michelle, looks like your line's open.
Good afternoon. My name is Michelle Montserrat Ramos, and I am with Consumer Watchdog. I know your response. You don't have funding for outreach to the public. I understand that. Although you do seem to have resources to focus on outreach for medical students and physicians in training. I do have to say that you did have one outreach event for the public recently in Fresno. This event was held in the middle of the day when all working class families are at work. Couldn't someone on staff recognize that the community you might want to outreach to might be unavailable because they are working? Would it be that difficult to hold an outreach event from 4 to 7 p.m. or on a weekend? You do realize that a campaign was run in Bakersfield and Kern County last year that engaged the community. During this campaign, their legislators were targeted, and you received upwards of 5,000 petitions seeking accountability and justice for families in that community. Given that there was such an emphasis placed in that community, why wouldn't you organize an outreach event in Bakersfield and on a weekend, or at a time where the community could actually attend and participate? Again, I speak to new people on a daily basis whose loved ones died tragically. They are not aware that your board exists. They do not know how to file a consumer complaint. I have talked to young mothers who sent the board an email as their consumer complaint. They thought they had filed a complaint, but never heard back from your board staff. Californians are not going to know that you exist until you outreach to them. In-person public outreach to consumers must be included as an objective. Thank you.
Thank you for your public comment. This time, President Lawson, I don't see any additional requests in queue.
Great. We'll bring it back to the board. Are there other refinements, or do the facilitators have any recommendations for us?
Madam President, this is Dick Thorpe. I just had a question about two items. One of them is, it seems like we've had some significant disconnect since HQIU was removed from under our jurisdiction. We have lost quite a bit of control. Is that something that, I know it's not under outreach, but I guess that's one of my concerns is that something that should be on our long-term agenda to try to bring HQIU back under the board's authority, number one. And then, shoot, what was the other issue I was thinking about? Well, that was one of them. I'm sorry, I should have written it down, but there was another one I had, but I can't think what it was now. But HQIU was one of the issues that I was concerned about. I didn't know if that was a legislative issue, or I mean, I guess it would be a legislative issue, and if that's something we're already working on, I don't want to burden the strategic plan with something different, but I do think we could be more efficient if the HQIU was back underneath our authority again.
I'm not sure where, I mean, that's an enforcement program issue. Mr. Pacifica is raising his hand. It's an enforcement program issue, but we need some changes to put that, I guess, to put the genie back in the bottle or whatever. Turn the clock back to 2019 or prior, right?
Can I just come in here? I think in terms of business administration, did we not say that we would look at the relationship with the Attorney General's office, and that would include HQIU? And in that context, that is something which we are actively doing. We put in place a new memorandum of understanding. We're constantly reviewing that. And what we could do is to bring proposals through to the board on how to improve that relationship. So, but then of course, to change the entire structure, if that was the ultimate goal, that would require legislation.
Well, Bill, let me ask you this: is that I thought I had heard it said? I thought it was maybe by you, but maybe that's not correct. But I thought I'd heard it said that the one of the issues with our ability to be as nimble and as efficient as possible has been that HQIU was removed from under our authority.
Yeah, well, I think again that is something which we look at, which we are examining. That's something which also the enforcement monitor is examining, and is something that will be looked at in the context of their report. I know previous boards have taken the position that HQIU, that those staff should be returned to the medical board. What we've been doing here during the time that I've been here is to take the existing situation and to try to manage it as effectively as possible. That's why we put in place a new memorandum of understanding. That's why we have weekly meetings. That's why we're engaging them on a more granular basis than we had in the past. So that's all things that we're doing now.
Dr. Thorpe, like the last item that TJ brought up. I think this is more not necessarily relevant to this process.
Well, that's one of the things that we can all agree on. TJ and I have been way too granular here today.
No. I mean, it's
No,
I mean,
that's fine. I'm fine without if we don't include it. Thanks.
Yeah, no, all good ideas. Just want to be very, very clear. Both yours and TJ's are great ideas. I think the more proper forum will be agendized at the full board and get a further update from Mr. Pacifica, and then how we can move forward to be more effective. Is my suggestion, but willing to hear from other members.
This is Tricia. Just based on hearing the public comment and also looking at the summary weaknesses from the environmental scan summary, there is a request for more outreach to consumers regarding the role and services that the board provides. So I don't know if you want to add an objective that addresses that.
Isn't that what all of these objective? I think that's what we were trying to get at with all of these in different ways. Could you go back to maybe the first slide for outreach? Right.
Although Christina can speak for herself, that's what I thought part of her looking back at the committee structure, et cetera, was actually here to do. Can we do a better job with a different structure on the year of outreach? That was my impression.
I mean, my impression also, Dr. Hawkins, was create stakeholder meeting structure, format, and topics to encourage bilateral communication was to address that desire for more communication.
Yeah. And again, I can't not make a comment about the idea of educating medical students, physician and training, which is how it started. I have no problem with expanding to licensee, but we don't have the money yet to do this. We've done it periodic in the past. This is one of the things I mentioned when I went before my Senate hearing, that this was something very, very important. When I have the opportunity to speak with medical students, I talk about the medical board, what it does, and protecting their license and the responsibility they have, the very special role that physicians have in this in the community, et cetera, et cetera. So that's my comment about that. This is a very important thing. It has to do with prevention.
And this is Tricia. My comment was just referring to consumers not knowing that the board exists or what services it provides.
I think I've heard and have actually mentioned in other forums the idea about reaching out to a broader audience of Californians so they actually understand who the board is and what we do. I think that's one of the things we've spoken about, and it just speaks to reaching out to, I'm repeating myself, the greater citizenry of the Californians to help us do our job better, getting their input, not to exclude anyone who's actually been in dialogue, which I'm agreeing could be better, but that there's a reason to broaden the discussion with additional groups, entities, for the purpose of education and doing our job better. Whether that has to be said as an additional outreach, I don't know. I don't want to be misinterpreted for anyone to think that I'm saying not to engage with folks we've been trying to talk to and need to talk to. I'm not saying that. I'm just saying it should be expanded.
Could you show us the second slide again, please? I mean, I guess there isn't a specific action item. I mean, under the first one, if you go back to the first slide, it does. Maybe if we create I don't know, create public communication, or maybe we need to just have another bullet that just talks about create public public outreach for the by all appropriate means, you know, whatever they had, you know, social media, email, I don't know, whatever it is, by all appropriate means, to clarify the role of the medical board and board to control, yeah, that's to clarify the role of the medical board, I guess.
Okay. Do you want to add anything about the services it provides or just clarify the
I mean,
role?
I just think, you know, I mean, that clarify the role is clearly that just includes everything we do.
Okay.
It adds another level of inclusivity, which is what I was speaking about. So it may in some ways seems to be a duplication, but I think it should stay in there.
Okay.
Hi, this is Michelle. Real quick, I want to get back to this idea of prevention and then this idea of outreach. So if we were to engage our licensees and consumers about zero harm actions and behaviors that they could be engaging in or doing, the why is to eliminate preventable harm. And I'm want to kind of go back over the concept again. What that goes back to is something about this bilateral, or I would say bidirectional behavior, or a bidirectional communication rather. But we really have to, and it goes to, I think, Dr. Hawkins' point on education, that we have to start talking about how do we engage the licensee and the consumer about the zero harm actions and behaviors that can be taken to eliminate preventable harm. So I'll give an example. Something to a patient versus what a patient may unknowingly do to themselves by not following up and getting labs and being monitored. What I'm trying to say is this engagement is two ways, and it has to start in the very basic education of our patients, our healthcare consumers, as well as it starts in medical school and it works its way up. It's very critical point, I think.
Yeah,
I want to address that preventable harm part. I think that's important. Preventing is better. Getting to the near misses, being a near miss is better than having a problem.
And are you referring to the objective that starts with educate, the first slide?
I'm trying to see. I think it goes educate medical students. This is about
yes.
engaging. So this could be a subtopic, but I'd still like to see something about prevention in there. And what are we trying to do? We're trying to prevent harm. So we're going to eliminate preventable harm by taking actions that are going to give us in that zero harm range. So I would say if you said an action is to engage, right? The consumers and licensees, you're going to educate, or you're going to engage licensees and consumers about zero harm actions and behaviors to eliminate preventable harm. Wordy, but the concept is, I think, I just don't want to lose preventable harm. Eliminating preventable harm is top of mind of every healthcare organization and should be top of mind of every physician and top of mind of every training institution for all licensees.
Okay. So that sounds like a new objective that would begin with the action verb engage, and then be consumers and licensees about, and then I missed that part, but it's to eliminate preventable harm. And
Dr. Ball, is this?
I'm sorry, I'm
were you
muted.
intending
I apologize.
Were you intending to include just a revision of the language from the item above?
I think I wanted to make sure that this part about eliminating preventable harm is in the idea of here. Where is it?
I think we can add that to.
I think that's what I'm thinking. We can add it. Think, yeah, I think that's fine. It's a concept, and it's an important concept of a culture of safety, of zero harm is the point.
Okay.
And I mean, there's a whole body of literature on this.
Like adding patients to the issue and adding preventable to patient harm in the why. So to reduce preventable. or eliminate preventable.
Eliminate preventable.
I mean, our whole goal is to stop an accident before it happens, right?
Right, that's
And,
correct.
and just to keep it really simple. And then, and the question is, how do you do that and what topics do you look at? I mean, this is a living document. We can, figure out those details, but those details shouldn't be figured out with just us. If we're going to have a committee of the stakeholders or interested parties, they should be telling us the topics so we can figure out how to implement it.
And then for the issue, we would need to add patients to that list, or else consumers. So medical students, physicians in training, licensees, and
I think we can definitely wordsmith this later. I just want to get the idea of the words eliminate preventable harm.
okay, great. All right, so it looks like we have 6 objectives for outreach.
Do you think that's enough? I'm not hearing any.
I think so. We got work to do.
Yeah, additional proposals.
Yes.
Yeah, we have a lot of work to do. So on my agenda, I have the next item is next steps from Ms. Cornell and Ms. St. Clair.
Yes, and I'll let Elizabeth.
Thank you, Trisha. So for our next, let me update this really fast. 6 outreach, that gives you a total of 29. So I'm going to ask you, how many years do you want your next strategic plan to be? We have a total of 29 objectives. Typically, strategic plans run from 3 to 5 years. We allow the board members to see how many objectives they have and identify the number of years they want their plan to be.
It's Randy, I throw out 5.
Board members?
That seems right to me, especially since in our sunset review process this year, we'll be asking for 4 more years.
I agree.
I agree.
Okay. Seems like it will be 5. The next steps, what we will do, draft the strategic plan with the objectives that were developed today. We'll send the draft over for review edits to the executives at the board. And that plan will be presented to you in another board meeting where you will get a chance to review, edit, and approve. After it has been approved, basically adopted, we offer action planning where we assist through facilitating action planning sessions to the board, helping them develop an action plan for each objective, identifying, let me show you here, identifying tasks that need to be accomplished in order to successfully accomplish the objective, due dates, establish performance measures. All of that we can help after the plan has been adopted. Do you have any questions for us today?
I don't think I have any additional questions. Do board members have any questions? So my understanding is this actually going to be ready for us at our December meeting, or are we looking at the meeting following that?
I can have the draft ready for the executive team, but I can't answer their question if it could be ready for the next board meeting.
Do staff know when we need to receive that in order to be able to have that ready for the next board meeting? It's coming up soon, right? I mean, in terms of.
I think realistically, we're probably looking at the February meeting.
Okay.
Yeah, we're finishing up the draft sunset report.
Right.
That's a big objective for December.
Okay. So I think we can expect that we'll see this most likely at the February meeting then. And that's in part due to the timing. We're well into agenda prep and and as Erin indicated, well into preparation of all the documents that go into that. So we'd really have to have it turned around in a week or two in order to make our board meeting. I just don't know that that's feasible. But that is our next, that's the last thing we have on our agenda. So is there any further comment? Anyone want to add anything before we adjourn for the evening, for the weekend? All right, seeing none, I will adjourn the meeting at 3:30. Everyone, hope you all have a happy Halloween on Monday and have a great weekend.
Yeah,
Thanks, everyone. Thanks, everyone.
Thank you.
Take care.
Hello? Like we didn't have enough Zoom for the day, huh? Marian said she's gonna join the conversation. Yeah. Yeah, you see, I've been on the board long enough that I should know that, and also that they'll never send shit to anybody. So I'll be aware of that. Yeah, they'll definitely after they will definitely ask for these records at some point, but they'll be careful. Like I said, no, I want it. I have to explain myself.